also have to have other jobs as our legislative duties are part-time, and this is where I spend my time and have my career. So welcome to Mercer. You know, I want to thank y'all all on the panel or on this committee for your time and commitment to this cause, because we all know that any alternative to opioid use is, I think, incredible. We all have stories of those we know that have had issues with opioids and led to much worse things in their lives. So I hope that y'all will come with some great solutions and resolutions. And Speaker Burns and all of the leadership and all the members, appreciate y'all's time for being here. And again, welcome to Mercer. And thank you for allowing me to say a couple of words. I'm gonna hang around for a while.
Thank you so much. It's a treat to be here on your campus. And I think we've got almost everyone here that is going to be here today, so we will go ahead and get started. I want to welcome everyone again. It is, I know you drove through some stormy weather to get here, so I appreciate that very much. Hopefully it will settle down and it will be better when we all head back to where we came from. So this is the second of 5 meetings for this study committee. To reiterate, the goal of this study committee is to understand the current landscape of both the country and our state in particular, and how we as a state can move towards more choices for consumers. Today we will have presentations from Mercer School of Medicine, Dr. Catherine Cheek, Maria Thacker, and Georgia Bio, and the Georgia Society of Anesthesiologists. As always, your questions are very welcome. Our microphones work a little bit differently. If you will just make sure to raise your hand if you have a question. Morgan and I are going to be watching out for it from each side. That's part of being on a different campus and using different stuff, but it's good to be here, so thank you so much. We will begin the meeting then. First of all, if I can introduce, please, Dr. Jean Sumner, the Dean of the Mercer School of Medicine, to come and tell us a little bit more about this great place we're privileged to visit and the good work you are doing. Thank you so much.
And committee members, welcome to Mercer. We're honored to host you today. I think all of you know that Mercer is a medical school that is devoted to our mission, which is helping rural Georgia receive the physicians and care that they so readily deserved, and looking at health disparities. And opioid abuse and use is a significant problem. So today, some of our faculty and colleagues that we're working with will present what medical students, what residents receive in training, and a unique program, some of the grants that we're working on, and just a sampling of that, and then a unique program that we found and are working with in 4 rural hospitals. So it's a pleasure for me to introduce Dr. Alan Tyndall. Alan is a long-term internal medicine faculty member. I could go through his CV. I won't. It'll take us all day. I'll say that Alan frequently is awarded the Outstanding Teacher of the Year by the students, and the nicest compliment I've ever heard is a student said, "Breathing the same air as Alan Tyndall makes you smarter." So take a deep breath. He's a good guy. Paula Camara is with us as well. She's a research associate. She's working on multiple opioid initiatives, but she also has worked very diligently on a maternal health grant as well through the center. And Carter Holder works with the Christopher Wolf Alliance, which is a program that we think really shows promise in working to prevent opioid abuse. And I'll let Carter introduce himself. He is a life care specialist, probably a term you haven't heard, but I think we'll hear in the future. But thank you for being here. Thank you for giving us the opportunity to sit in on this and for the work you do.
Good morning, and thank you for inviting me. I'm Alan Tyndall. I'm an internal medicine doctor here at Mercer, and I primarily work with the medical students and the medical residents. So my friend Dr. Grimsley, sitting in the back, introduced me to Paul Seal. And Dr. Seal, who was part of the Mercer-Macon faculty, had obtained a large federal grant addressing alcohol and recreational drug use. So I began my career into the screening and treatment of alcohol and opioid use disorders in approximately 2012 by participating in Dr. Seal's grant. I was the Savannah liaison for training residents and students in SBIRT and implementing SBIRT in the ambulatory clinic. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. In Savannah, we were trying to implement more detailed alcohol use disorder screening in the electronic medical record, which was EPIC. Several years later, inspired by Dr. Seal, I participated in the training to become a buprenorphine prescriber. Today, that training is no longer necessary to prescribe buprenorphine, but anyone with a DEA license can prescribe buprenorphine, but they must receive at least 8 hours of this or similar training. The training will apply to the prescribing of all controlled substances. We at Mercer are presently trying to incorporate training in prescribing controlled substances in our residency training program and in the medical student curriculum. Though we have incorporated opioid training into our curriculum for both residents and students, this is a work in progress. For example, in the hospital and in our outpatient clinic, residents are routinely checking the PDMP, Prescription Drug Monitoring Program, for any patient requesting or receiving medications that raise concern for dependency. When we prescribe narcotic pain medication, we encourage the patient to pick up naloxone, brand name is Narcan, without prescription at the pharmacy. What we are still trying to decide is how to come up with a standard 8-hour course for residents and potentially students to satisfy the DEA requirement or their future DEA requirement. At least one of our students has taken the same training I completed, and as of December 2022, this training was still free. So there are many options outside Mercer, but some are for a fee. Solutions to the misuse of prescription opioids, as well as to the increase in heroin use in recent years, include prevention efforts, use of prescription drug monitoring programs, naloxone to lessen the likelihood of overdose death, and the effective treatment of opioid use disorders with MAT, medication-assisted treatment. The residents, the medical residents, use the Georgia PDMP frequently, so I don't use it much anymore. It appears the last time I made an inquiry was in February of 2023. Oops, sorry about that. So February of 2023. The PDMP allows you to see what medications a patient is taking and who else is prescribing those medications. Though the PDMP is a state-run function, other states can be connected. So if you're in Savannah, you can connect with South Carolina. Hospital electronic medical records can also connect directly to the Georgia PDMP. The PDMP can send you email alerts when there is concerning activity related to your patients. Current FDA-approved medications to treat opioid use disorder include buprenorphine, methadone, and naltrexone. We need to do a better job of identifying and treating patients who would benefit from receiving buprenorphine. Methadone requires a special practice. Naltrexone, I have never prescribed and am not familiar with it, though some of the psychiatrists that I know use it. Buprenorphine seems to be the medication best used by primary care physicians. So I've given several presentations on this topic, and this is a slide I've used in presentations since 2016. According to the CDC's morbidity and mortality report of that year, there were over 59,000 overdose deaths reported in 2016. Put in perspective, that was more than the number of American deaths that occurred during the entire Vietnam War. And that was in 1 year alone. The American military was involved in Vietnam in one way or another for almost 20 years. So you can see that the opioid crisis is an important ongoing event, equivalent to a Vietnam War every year. And since 2016, the problem has only gotten worse. Drug overdose deaths peaked in August of 2023, about right here, at 111,447. There's been a slight downturn since then, with 99,684 deaths reported in March of 2024. And this is a yearly number from March 2024 back to March 2023. The next time I give this talk, I'll superimpose a graph of COVID-19 cases. I believe it will match or slightly precede the increase in overdose deaths. I believe COVID started in early 2020, so you can see that after that time there was a pretty steep increase. And there have been 3 waves of opioid deaths. Prescription opioids, the rise in heroin, and most recently synthetic opioids. The synthetic opioids appear to be driving the overall increase. Here's the overall increase, and then synthetic opioids, and this includes fentanyl. So Mercer is addressing the opioid epidemic in Georgia through past, recent, and current grants. My colleague, Sherry Williams, provided these slides and descriptions. So in 2019, Fannin, Gilmer, Gordon, and Polk counties, these are counties in northwestern Georgia, were being significantly impacted by the opioid epidemic. Mercer formed critical partnerships with stakeholders in those counties to create the North Georgia Opioid Prevention and Education Network, or OPEN. Since that time, this program has been awarded 4 separate grants totaling $1.6 million. The North Georgia Open Consortium remains active and meets on a monthly basis. This consortium includes recovery community organizations, faith-based organizations, schools, courts, public health departments, and community members. These are some of the significant accomplishments stemming from the grants. We've distributed a number of kits that allow for the safe disposal of narcotic medications. We've distributed about 4,000 doses of Narcan and trained community members in their use. We've established a recovery community organization, and we've trained 8 certified peer specialists. peer specialists are persons who have struggled with opioid use disorder in the past and who are now teaching and helping those who are currently addressing that issue. And now my colleague, Paula Kamara, will demonstrate our website. And let's see.
Thank you, Dr. Tyndall. Good morning, everyone. My name is Paula Kamara, and I'm just going to give a brief overview of the North Georgia Open website, northgeorgiaopen.net. This website serves as a hub for prevention, education, treatment, and recovery resources for opioid use disorder. Can you hear me now? So this website serves as a hub for education, prevention, treatment, and recovery resources for opioid use disorder. And one of the common things we heard from members in the community is that people want to get help, but they just don't know where to go or where to start, how to start. So we created a centralized location where members in the community can come and look up the resources that are available to them in the community, in the service region, and beyond. So I'm just going to quickly run through the different tabs there at the top. But this is our beautiful website. This is the home page. And then the About tab kind of gives an overview of North Georgia Open. And under here, you can also find a list of our consortium members. North Georgia Open operates as a multi-sector consortium, and these are the amazing men and women that are out in the forefront combating the opioid epidemic in their communities. And if you click on each of their names, you'll be able to be directed to their website where you can learn more about who they are and the work that they're doing. And then under the Our Region tab, gives a little overview on opioid use, some information, some data on that in the region for each of our counties that we serve. And then the services section talks about the 4 initiatives that North Georgia Open focuses on, which are prevention, education, treatment, and recovery. So it kind of gives a little bit more information on that. And then the resource section is the meat of the website. This is where we have compiled the resources that are available in each of the counties. And if someone wanted to find a resource in their county, let's say for recovery resource, they would just simply come here and they'll click on their county of residence and they'll be able to see a list of the resources that are available. And we made it where the resources can be filtered by category. So if someone's looking for recovery, they will see all the list of the resources. And for each resource, we included the address, the phone number, the website, and the description of the services that they provide. So they will be able to directly contact them to make it a little easier. And then also, in addition to having recovery or treatment resources, we had other resources that we feel will be helpful to include that are available in the community, like food assistance, childcare, and things of that nature. We also have educational resources that we have compiled, and we have resources for both community members and healthcare professionals. We have materials that can be printed. I'm sorry, I'm kind of trying to fidget the pad here. So we have educational materials that can be printed. We have links to trainings that are free or low cost that community members or healthcare professionals can take. And then continue educational courses too for healthcare professionals. And then under the events section is where you can find out about the events that are happening that our partner organizations are hosting, or if North Georgia Open is hosting an event, you can also come here and find out where events are going on. And then finally, the contact tab is where you can reach out to us by filling out this contact form or emailing us at northgeorgiaopen@mercer.edu. But this is just mainly just a brief synopsis of the website. So if you're interested in North Georgia Open, feel free to contact us. Thank you.
So, Project ECHO was a sequence of virtual Zoom conferences that we held in conjunction with our previous opioid grant. 3 medical students who are now medical residents participated in that grant. They're all in good, strong, reputable residency programs. Let's see, University of Arizona, Kennestone in Marietta, and Houston, University of Texas. We trust that when they complete their residencies, they will set up primary care practices in Georgia and be well trained in opioid use disorders. So we're continuing Project ECHO. Mercer School of Medicine students Chloe Boynton and Christy Jones, who unfortunately couldn't be here today because they have other responsibilities as medical students, they're studying all the time, are developing and managing this year's Project ECHO sessions. They put together an incredible lineup of experts on substance use disorders. So they're running the show. We teach the residents and students, and they in turn are teaching us. Regarding the opioid crisis, there is cause for optimism. And here's a little optimism from 2018. And I think these points still apply. I wrote them myself. I didn't copy or paste. Begin with education. Education is making more prescribers, including residents, aware of the potential that their patients may risk opioid misuse. We also teach students about opioid misuse. We should continue to improve our teaching, making it more frequent and systematic. Physicians are more cognizant of the need to avoid use of narcotic pain medications for treatment of acute pain, especially if that pain is not severe, or at least limit the dose and duration of pain medications. Prescribers are receiving more information regarding the use of adjunctive modalities of therapy to treat acute and chronic pain. These are things like physical therapy, massage therapy, acupuncture. Prescribers are using, indeed are required to use, prescription drug monitoring programs much more frequently, and more PDMPs are communicating with one another. Prescribers are monitoring patients more closely for signs of opioid use disorders and are more likely to refer persons at risk to treatment programs. Naloxone is more readily available at your local pharmacy, and there are programs to distribute naloxone, as in our grants, to persons with opioid use disorder, potential opioid use disorder, or those who are taking an opioid medication for therapeutic purposes, and to their families and caregivers. There are actually health departments in the state who distribute naloxone at no cost. There are naloxone boxes set up around the state that provide naloxone and fentanyl testing strips. And now I'd like to introduce Carter Holder, a life care specialist and director of operations at the Christopher Wolf Alliance. Cami Rice originally sent one of these videos to Dr. Sumner, and Dr. Sumner responded to her, and thus began the collaboration between Mercer and the Christopher Wolf Alliance. So, Carter.
Good morning, everyone. I want to thank you for having me here to speak to you about our program, but I want to shout out Dean Sumner and Dr. Tyndall for all their work that they've done to make the life care specialists possible. They're really instrumental, so thank you to Mercer University. I want to start with a video from our founder, Cami Rice. She's really sad she couldn't be here today, but she's going to tell you a little bit about why we're doing what we're doing.
Raise your hand if you know someone who has died from a drug overdose.
Sorry.
Raise your hand if you know someone who has died from a drug overdose. We all know one. One family member, one neighbor, one friend. Addiction often starts with that first prescription. Patients enter a healthcare facility in need of treatment for sickness and disease. But treatment can result in pain, and the medicine used to alleviate this pain can slowly build a bridge to addiction. CWC has a solution. We call it the Life Care Specialist. Life Care Specialists partner with physicians and clinical teams. The Life Care Specialist acts as a protective barrier between pain management and addiction. A trained medical professional whose only mission is to add one extra layer of care to help prevent dependency. The flagship Life Care Specialist program is being piloted by Grady Hospital in Atlanta, Georgia, with our intent being to expand this pilot program to healthcare systems nationwide. Life Care Specialists are certified with the Trauma Resource Institute, providing mental health techniques for patients experiencing these intense anxieties, stress, and PTSD. CWC believes the best treatment for addiction is to simply stop it before it starts. Why should you care? Because we all know one family member, one neighbor, one friend who has lost their life from a drug overdose. I know one, Christopher, my son.
It's hard to follow that. Some powerful words. So I'll give you some context on Christopher's story. Christopher had a series of health challenges. This was in the early 2000s when pain was declared the fifth vital sign, and his very well-intentioned doctors sent him home with 90 Oxycontin with a refill for 90 more. That's how his addiction began. Through a need for pain management, a need to regulate the anxiety and the stress of being a teenager that has to go to the hospital and spend 70 days in the hospital. He fell through the cracks. There's a gap in healthcare that did not serve him. So that's why we built this role. The life care specialist was modeled after everything that Christopher did not have in his journey. We took lessons from other paraprofessionals in the health system. The child life specialist is why we call this the life care specialist. Child life specialists in pediatric healthcare meet with kids if they're anxious, if they're in pain, if they've got to undergo a procedure. They provide distraction tools and games and things that make it exciting for the kids. There's no equivalent in adult healthcare. So that's why we built this role. It was established in 2019 at Grady Memorial Hospital, first under the leadership of Dr. Mara Shanker. We started with orthopedic trauma patients. And we've been told many times, if you can be successful at Grady, you can be successful anywhere. And we were so thankful to be welcomed by the team at Grady. So we started meeting with people post-operatively in the orthopedic trauma service at Grady. And over time, we built the intervention. We built all the different tools that the LCS has to provide to patients. And you can take a look at some of those here. Our primary goal is opioid prevention, opioid misuse prevention. So with all of our patients, we do an educational lesson on the medications that they're taking, if they're being sent home with opioids, how to take these medications safely, how to store them safely, and when it may be appropriate to switch over to another method of pain control. Ultimately, we don't want anyone to leave the hospital thinking that their only defense against pain is a narcotic medication. We think of pain management as a holistic process. We have a toolbox, we have a set of tools that we can provide to patients, and the opioid may be a very important tool in that toolbox, but it's not the only one. In addition to this opioid education, we provide patient-specific interventions related to mental health and pain management. We do relaxation exercises, distraction exercises. We provide them with games and things to do to help distract from their pain. But most importantly, we're a listening ear. We take the time. With each case, we have about 45 minutes to an hour each session to sit down with them and understand their pain, to validate their pain, and then to build trust and rapport so that we can help counsel them on the medications that they're taking. In doing this, we learned that people are going through a lot. There are a lot of different factors that influence someone's pain. So the more we talk with patients, the more we're able to uncover comorbidities that could either be influencing their pain or put them at risk for a substance use disorder. So a big component of our intervention is recognizing these social indicators and then referring them to a service either within the health system or externally to help with that whatever that is. I can remember numerous cases. Somebody comes in for a broken ankle, and the more I talk to them, I realize there's a domestic violence situation at home. That contributes to their pain, and that also puts them at a higher risk of developing a substance use disorder. So if I'm able to identify that, connect with the healthcare team, make sure that everyone's aware of that so that we can provide that patient support, we believe that helps better their outcomes. So when we started this program, we started with orthopedic trauma. Since we have grown within the Grady system, we're seeing all surgical cases that are referred to us. We're also seeing chronic pain populations, so individuals with cancer. In particular, the sickle cell community deals with intense pain crises and often have to be on long-term opioid medication. For those patients, our goal isn't necessarily to discharge them from the opioid medication, but to give them alternative methods of pain control. So as we've grown within Grady, we wanted to create a model with which we could scale throughout Georgia. And we were very lucky to have been awarded a $1 million grant from the Rollins Foundation that has allowed us to scale to rural communities within Georgia. This is when we got connected with Mercer University School of Medicine and the Georgia Rural Health Innovation Center. We partnered with them and said, we need to build a training program that can equip LCSs hired all over Georgia to provide this intervention. And that's what we did. We created this training program in a similar fashion to how other healthcare professionals are trained. There is a curricular aspect. You have your first period of didactic learning in the classroom, and then you have a clinical aspect where you're able to apply the learned materials in a clinical setting. So you can take a look at the different modules that we have in our online training. We've pieced together all the things that we think are important for the LCS to be knowledgeable on. So of course, opioids and substance use disorders, addiction, but also mental health and wellness, pain management approaches, grief and mourning. We work with a lot of people who are grieving loss, and to be able to handle that is very important for the LCS. Two big components of our intervention are the community resiliency model. This is a series of behavioral-based interventions introduced by a group in California that are provided at bedside that help an individual calm down their fight or flight response, control their autonomic nervous system, and re-engage their executive functionings through sensation awareness. So all of our life care specialists are trained instructors with the community resiliency model. They're also trained on things like motivational interviewing. We are not therapists. This is a paraprofessional role, but we use certain skills that talk therapists use to build rapport with our patients. Following the completion of the online curriculum, the trainees then come visit us in Atlanta at Grady Hospital. This is our training hub, and go through a clinical shadowing rotation. Here they're able to apply their learned materials, learn how to deliver the intervention. They can practice it in simulation environments and then actually practice it on the floor with patients at Grady. Next, I want to play a brief video of Dr. Mara Shanker. This is our Chief Medical Officer at Christopher Wolf Crusade, CWC Alliance, and she's going to talk a little bit about what the life care specialist has meant for her practice. She is our champion, and she was instrumental in the founding of this role at Grady. So I want you to hear a few words from her.
My name is Dr. Mara Shanker. I am the Chief of Orthopedics at Grady Memorial Hospital and the Chief Medical Officer of the Christopher Wolf Crusade. So why do we need life care specialists in our hospitals? At Grady Memorial Hospital, we are one of the top 2 busiest orthopedic trauma departments in the United States. We see a lot of patients who have tremendous injuries, a lot of pain, a lot of underlying medical and social comorbidities that contribute to a lot of pain. And when we're the physicians in these busy hospitals, we don't have a lot of time to be able to really understand a lot of the underlying issues that our patients have surrounding their pain and their perceptions of their pain. And since we started the Life Care Specialist program at Grady several years ago, we've had a lot of patients come through who just need someone to talk to. They need somebody to understand what their pain experience is like, and they need somebody to be able to give them a very personalized way of being able to get through their pain. And so one of the other things that the life care specialists can help our patients with is a lot of the mental skill set to help them deal with the anxiety surrounding their pain. And so that's something that as a physician in a very busy office where I'm seeing sometimes upwards of 60 patients in our clinic in a relatively short period of time, we can't really sit down and help them with their mental wellness skills to help them cope with a lot of their anxiety surrounding their post-traumatic stress that they experienced from the trauma that they had that led to their injury, and that really is a ongoing spiral related to the anxiety associated with their pain. Just having an ear to listen to them and to understand that, and then provide them with that skill set of mental wellness techniques is extraordinarily helpful. Our experience with the life care specialist has been really remarkable. They sit down with our patients, they talk to them about their pain, they educate them on the risks of opioids, how to safely dispose of medications, how to use life-saving Narcan in the event of an overdose, and they really help them use non-pharmacologic or non-medication versions of pain control. So that varies very much depending on who the patient is and what their preferred method of what we call behavioral-based pain interventions is.
So when we started at Grady, we did a pilot program. We enrolled 121 participants into this pilot study where we met with them, the life care specialists met with them following surgery, We provided the intervention, and then we followed them for 2 weeks. We found some great data from this. First of all, there was a reduction in opioid utilization compared to historic measures of opioid utilization in the same population. This indicates to us that we are helping manage their pain, and through our opioid education, individuals are managing their pain in other ways rather than relying solely on the medication. Pain decreased from admission to 2 weeks postoperatively. Importantly, we had patient satisfaction increase. That was a big measure. This, we believe, is a value to the health system, and patient satisfaction is really important to track. Importantly, 99% of participants agreed that the intervention was helpful in managing their pain, and we're really proud of that. Also, we noticed that the interventions that we provided were actually used. We can provide these skills, but if I'm in a lot of pain, I'm in the hospital, and I'm given medications, and somebody comes and tells me to take deep breaths and squeeze my muscles, compliance is not always that high when you're in a lot of pain. But we found that on average, each patient used an average of 2.8 of our different skills, which is promising, indicating that individuals are willing to explore other methods of pain control. So that was a small pilot study when we were just getting started, and we're planning to grow from there. We've proven feasibility at Grady. That is our blueprint, and now we want to build a model to scale. So you see on the right-hand side of the slide where all we're going. We were just asked to bring 2 positions to Emory Healthcare in the Musculoskeletal Institute, primarily with their orthopedic surgeons there. And then as a part of this grant to expand within Georgia, we're moving to 4 hospitals all throughout Georgia. 2 LCSs have already been hired. We're in the process of hiring more. And when we implement those programs in rural Georgia, working closely with Mercer, we will provide a program evaluation to assess how is it different? What ways do we need to change our intervention? What does it look like with a different landscape in this different type of hospital? And how can the LCS be of value to a rural community? We also have just launched 2 hospitals in Arkansas. This was done through a different funding mechanism. We got to know some folks in Arkansas who asked us to bring the program there, and we worked with 2 hospitals that applied for state settlement funds in Arkansas solely to implement a life care specialist program. So we're working with these 2 hospitals, essentially providing the blueprint of what we did at Grady, giving it to these hospitals and saying, here's how you can start this program. We will train all of your LCSs. We will sort of be remote supervisors in order to help them do their best work as life care specialists. But that's our goal, is to have this program in healthcare systems nationwide, but especially in Georgia. And I'm excited to share and hear any questions that you have about this or about any of the other programs that we've talked about. So thank you for the time.
Thank you, too. That was great, very interesting. I'm sure that among us we may have some more questions, and I'm going to suggest, and see if Justin is amenable to this, that if anyone has a question, if you'll just raise your hand, and then he'll activate your microphone, and we'll go forward with that. So we are open right now for questions. We can start here with this program, and then our other presenters are also at the podium as well. Are there any questions?
Can you guys hear me?
Yes.
Okay. Wonderful. That website is phenomenal. I think that is such a wonderful resource. I wish every county had it. My hats are off to you. But I did have several questions. First, about open. I know that you said you were doing some interventions within the schools. I was assuming you meant high schools and middle schools. What exactly are those interventions that are being done in the schools?
We have some of our community partners that go in, and they have some curriculums that they provide and kind of go through with the students. at some other school regarding like opioid use, misuse, and all that, and about resources that they can use.
Wonderful. Perfect. And then I also had a question about the Chris Wolf Crusade. These life care specialists, I understand that they have to go through a level of training prior to receiving the employment, but how are they chosen? What's the criteria? Do they have like lived experience? How are those selected?
That's a great question. So we wanted to make this role accessible, and we believe that the best life care specialist is not somebody that has a specific degree, but somebody that has compassion, empathy, somebody that is eager to be an agent of addiction prevention. So in doing that, we kind of created the training. So there aren't any specific qualifications that we're looking for. I'll tell you, we have life care specialists who have been peer specialists who use their lived experience through the role. That's not a requirement, but that qualifies someone certainly for the role. We have life care specialists that were nurses and want to do something different. We have a life care specialist that worked in the criminal justice system and is passionate about addiction prevention. So there isn't a set background that we're looking for, essentially.
Thank you so much. Amazing presentation. Thank you so much.
Thank you.
I can go ahead. My question, maybe a few, is primarily for Dr. Tyndall. When you were discussing, I guess, the various medications that are used in relation to opioid treatment, or treatment of opioid addiction, so primarily buprenorphine and naltrexone, for my question. And this is not a criticism, but you mentioned that you're not as familiar with naltrexone. Can you explain, like, maybe why there is a gap in the education that doctors may have as related to that medication? Because, and just as a layperson, I very well may be completely inaccurate here, but my understanding is that there's a lot of benefits to naltrexone versus buprenorphine in terms of, the lack of psychoactive properties, the lower likelihood of misuse, the ability to have an injectable 30-day dose, so you don't have to, so someone who's struggling with addiction doesn't have to wake up every day and decide, am I going to take this or not?
Please send me that article. I really don't know a lot about naltrexone. There is the advantage of its being long-acting. That can be a disadvantage too. If you have a side effect, you can't really stop it. I don't know that there are any reversal agents. I'm just more familiar with buprenorphine. The reason everybody doesn't have kind of a uniform training is that, psychiatrists get training, family medicine residents get training, internal medicine residents get different training, and we're all in our little silos in a way. We come together periodically, but I don't think we all have the same expertise in this area. I think psychiatrists, if they have an interest in treating opioid use disorder, are probably the most expert. And then anesthesiologists probably have different training and approaches also. So I think there's a need for us to all kind of get together periodically and share what we know.
My question is for Mr. Holder. Wonderful presentation. Just a couple questions related to this life care specialist. I know I was just reading the article on the initial pilot study in traumatic ortho, but two questions. One really around, it seems to be the model has been kind of linked to hospitals, and I don't know if that's because of the nature of the trauma ortho, but have you thought about pushing this model, or maybe it already is, in more of a kind of preoperative and also outpatient world? Because I think there are many more patients that would benefit as well from that. And then the second question is also, around, looking at this more of, outside of the hospital, again, the outpatient options, and potentially, what do you see those for?
Yeah, that's a great question. So you're correct. We did start primarily in the inpatient environment, post-surgically. When you're dealing with orthopedic trauma, there's not really a preoperative opportune time to meet with people. But you're absolutely right. As we move on to other populations, both within the specialty of orthopedics and beyond, we found a lot of opportunity to meet in the clinic, also to do preoperative counseling. We started a randomized controlled trial funded by the National Football League and Players Association. They're really interested in non-pharmaceutical methods of pain control for their athletes. And so they awarded us a grant to study the effects of a life care specialist both preoperatively and via telehealth for athletes, sports medicine injuries. So that's one way that we're investigating preoperative intervention. But especially in our rural communities, we're looking at all sorts of different deliveries for this intervention, not only inpatient, but also in outpatient settings, also in community-based settings. We're focused on the opioid epidemic within healthcare, but we believe that it permeates through the community, and if you can engage community leaders with the material that we're doing, we want it to reach as many eyes and ears as possible. So yes to both of those points.
Thank you.
Couple questions I'll just ask you since you're already up.
Sure.
How is what y'all do different, and how is what y'all do in interaction with the pain department? I don't assume, I used to be there at Grady. There's a pain department,
Yeah.
as is at Emory and everything else. So they're doing acute pain service, there's a whole pain service. Obviously those are professionals, you guys are paraprofessionals. Is there, are you underneath their umbrella, or do you sort of do your own thing? Because when they consult y'all to come in and help with ortho trauma, why would they bring you in versus the professionals that do that every day?
Yeah, so we operate primarily as a prevention service. So if somebody is in excruciating pain that has been long-term, maybe exacerbated by past substance use, there are certain cases that are not ideal for the LCS to see. And we know when those times are when we hand it off to the pain management service. We also frequently work with addiction medicine. There are moments where we're brought in to consult on a case, and the case is, I don't want to say too complicated, because we have skills that we think could benefit any patient, but there are additional needs there that we can't fill, and we know when to hand the baton. So really, we work in conjunction with those other teams. We're not meant to be a replacement for any clinical professional, but a value add.
How are y'all reimbursed? Is it just through the grants, or is there like a code that you guys bill for your services?
That's a great question. We don't have a billing code right now. That is sort of our North Star. That's where we would like to be. But right now, there are a few different funding mechanisms. Grady and Emory have both taken on the cost of the life care specialist program. We funded, CWC funded the position for 2 years. We collected data and we presented to the hospital. They said, we love this, we want to sustain this program. All of our rural hospitals are either grant funded or funded through state settlement money, as the case in Arkansas. So currently, it's mostly grant funded.
But the goal is to make it a viable professional with a business.
And we're also investigating ways that we can prove economic viability. So if a life care specialist prevents 2 to 3 patients from coming back to the emergency department for pain control in that 30-day postoperative period, that's essentially paid for the life care specialist for a year. So we're exploring ways that we can not only show the increased patient satisfaction and the benefit to patients, but also the economic value to the health system.
The study you guys did, how many, what was the N? What was the number of patients?
121.
121. And how did you guys measure the outcomes?
So opioid utilization was measured inpatient as MME, milligram morphine equivalent. for all of the inpatient days, and then once at discharge through their discharge medication. Pain was measured with the pain numeric rating scale 1 to 10. And then the rest of our outcomes were measured through surveys.
Thank you for your answers.
Yeah.
Just had one question for you, doctor. Just had a question. This was more just overall. On your optimism slide, it spoke about opiates. It sort of said pain meds, or basically taking the pain meds when you were talking about using opiates, and then using adjuncts, I think is the word used. I'm not sure. I don't have the slide up. But to pain. What I'm curious about is how much are we educating not just the pain specialists? You know, obviously I have a little bit of a bias because I did all that training, and I didn't really get that training till way later fellowship. What are we doing at the medical school level now? Because now it's different than when I went to medical school, where we understand, like we were talking about today, how much opiates can really hurt, even on the first dose. And like antibiotics, I remember when I was in med school, it was all about don't just give antibiotics to everybody who walks in with a sniffle. We were beating that into our head, and it really worked, right?
Yeah.
How much are we doing that with opiates, and how much are we saying, hey, opiates is not pain management? You know, there is other stuff that we can talk about, medication even wise, you know, not just physical therapy and massage and all that sort of stuff, but what medicines are we teaching med students on an early level that are, these are pain medicines as well, not just Oxycontin, blah, 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 blah,
Yeah.
you know?
We're using more like things like tramadol, gabapentin, topical diclofenac, Voltaren. So we're trying to stay away from narcotic pain medications. And when we do have to resort to narcotic pain medications, we're not giving a 90-day supply. You know, we're giving maybe 3 to 5 days. We're also giving them some doses of naloxone, Narcan also, if they're going to be on narcotic pain medications. As far as education about all the adjunctive modalities, which was actually on this slide, there's a pretty good list. These are, you know, these are pretty creative. My list is physical therapy, massage therapy, acupuncture. That's about my list.
No, what I'm trying to say is what I'd like to see in medical school education, what it sounds like you're doing, is not using the word pain management synonymous with opioid.
Right.
It should be pain management is gabapentin, tricyclics, blah, blah, blah. These are pain medicines, right? These should be our first line drugs, not, hey, the guy came in, he's got a broken arm. We have to go straight to narcotics. You don't even have to use narcotics in broken arms. We do it all the time.
Yeah.
You know, so I'm just wondering, are we doing that education on the front end so that we don't have to do it later on? Because once we get it ingrained in medical school, it becomes sort of our mantra, right?
Yeah.
Pain management isn't just opiates. It is all these other things, hopefully first.
We're doing that education. We need to do more of it.
And that'd be the other question is how can we do it better? How do you think? I mean, you obviously do this every day and you do a fantastic job, but how do we do this better at that level so we don't have these issues later on?
Yeah, I think we need to have a more systematic approach. We need to have more time. We need to get various departments together, you know, pain management people, internists, family medicine, physicians. And I'm interested, do you have any ideas as to how?
No, I agree. I think, but I was wondering more on like a national level, even at a Georgia level. Is it going to take more funding to make an education program? Is it more just getting with the professors and saying, how do we get this education a little earlier on and make it more holistic versus, you know, we're going to get guys in training and residency. Maybe they'll pick it up along the way, but maybe by then they've already worked in an ER where they just write scripts out and they don't really think about it.
Yeah, I think more emphasis on the topic will make it better over time.
Thank you for your answers. Appreciate it.
Thanks.
Good morning. Thank you so much. I'm Representative Lynn Gladney from the Augusta area and wanted to know if you had inquiries from other medical universities like Augusta University or the Medical College of Georgia or UGA to participate. And is there opportunity for that? Like the gentleman speaking before me, it seems that there needs to be more a broader scope of education at the early.
Is that a question for me?
Yeah, for either one of you professionals that could possibly answer that.
Our grant, North Georgia Open, we did collaborate with Morehouse some, and Dr. Aaron Johnson over at Medical College of Georgia or Augusta University, and I talk occasionally. And we have a Zoom meeting now that I think is monthly, where all the Georgia folks who are involved with these HRSA grants will get together and talk to each other. But there needs to be more cooperation among the various medical institutions.
The Augusta area, Augusta University, the student or university portion was just taken over by portions of that by Wellstar. And so we have a gap of continuum of leadership there that may possibly not necessarily have the foresight or the insight to know exactly what you do because of that gap. And is it okay if I forward your information to specific contacts in my area?
Sure.
That I know that support this cause?
Sure.
Thank you, sir.
I had one last question for you, Doctor, actually, and it's also referring to your optimism slide. One of the bullets says we refer those who are at risk of treatment programs. How are you identifying those who are at risk? Is it just through the prescription drug monitoring program, or are there other variables that you use to determine an at-risk individual?
Let's see.
The fifth one, I believe.
Fifth one. I'm not sure we have any kind of system as to how we refer people. We need a better way to do that. We refer people out if they need long-term narcotic medications. We refer them to pain specialists. If people need really intense treatment for existing opioid use disorder, there are some people in town who specialize in that, but it's more of an informal, asking, do you know somebody we can send this person to? I don't know of any formal way to find out who's doing what.
I mean more, how do you identify people that might need to get referred to treatment programs? Is it just through the use of the prescription drug monitoring program, or is there other evaluation that's done to identify who may need to seek out a treatment program?
Oh, I see what you mean. Yeah, I think seeing them in the clinic and kind of assessing them just from a clinical perspective. And if we do, we don't typically do periodic drug screens, but if that becomes positive, then they may need more expert treatment. The PDMP, drug screens, and just a clinical evaluation.
Thank you so much.
Are there any other questions? Thank y'all so much. I know you have gotten us all thinking in a very good way. This is some wonderful information. I thank you not only for sharing with us, but for the work that you are doing in this field particularly. It's so vital and so important. Thank you. I want the members to know that you should have the information from the Christopher Wolf Crusade in this white folder there. And anything else that is presented today from our presenters, Morgan will be sending it to you electronically. So we will have that. And as we continue to reflect and focus on this and prepare for the report at the end of our meetings. So next we have a presentation from the Georgia Society of Anesthesiologists from Dr. Bob Lane, who will join us now. And Dr. Lane, if you'll tell us a little bit about yourself as well. Welcome.
I will do that.
Thank you.
Jet Toney, who is the executive director for the Georgia Society of Anesthesiologists, asked me if I would come and speak a little bit about what role anesthesiologists might play in prevention of the problems that we're talking about here today. And you'd say, well, why in the world am I hearing from an anesthesiologist? Well, surgery or trauma, but surgery in particular, is the kickoff for drug use disorders in a large number of people who become ultimately and chronically addicted to medication. Believe it or not, the most common exposure of a young person to opioid medications is having their wisdom teeth removed. And I don't know if you guys realize it, but the oral surgeons, and I'm not bashing them, the oral surgeons typically give a drug called Meprigan Fortis for postoperative pain after wisdom teeth removal, which is 50 milligrams of Demerol and 25 milligrams of Phenergan in each tablet, and they're just wonderful. Everybody loves them, apparently. Had 5 children, and all had their wisdom teeth out, and I learned very quickly when the first one came home after his wisdom teeth were out, and a bunch of buddies came to check on him, make sure he was okay, and when they left, there were no more pain pills in the house. They had taken them. And so wisdom teeth removal or surgery, where someone gives you a lot of medication and your surgery's over and you don't really need it anymore, but you still got it. What could we do with this? The optimism slide of Dr. Tyndall's that we have referred to several times now spoke to one issue that is very important, and that is the education about what is proper dosing for these medications after a surgical procedure. My wife had a big procedure, required an overnight stay, and her surgeon gave her 5 milligram Lortabs and said, break these in half, take what you have to take. And she used 2.5 of them. And that was all. Compare this with in the 80s when I first came into practice and you had a knee scope, which we now know we don't even do knee scopes anymore, rarely. And that patient would get 40 tablets of Lortab with 3 refills, 120 tablets. And if they called back in or went back in, they just got more. So we have educated and we have improved a lot on what is given by prescribing doctors after surgical experiences, because you really don't need near as much pain as you thought you did. From the anesthesia standpoint, I remember the first drug-addicted person I encountered, which was when I was doing my senior elective at the Medical College in Augusta. And this was an anesthesia resident who had had a knee scope, and he would later say, after rehab, he would later say that first dose of Demerol that I got in recovery room was the best feeling I had ever had, and I spent the rest of my addicted life trying to get that feeling again, and I never got it. And if you've had any family members or friends, and I have, who have been through recovery, that is a very, very common scenario. So one change that I've made in my practice, because we give, we've got the best medicines, and we give the best medicines, but I don't give anyone who's awake opioid medications in my anesthesia practice, because if I give it to you awake and your last thought is, wow, that was great, then that may be the nidus for you having a problem. We get off to sleep, and then if we get to the point where I feel like an opioid is indicated, I'll give it then, and then at least they don't have the fun part of the experience, and they just got the pain relief. Someone alluded earlier to the really seminal study and paper that came out in the, I guess, the early 90s on pain as the 5th vital sign. I can think of very little that's done more harm than that thinking. And I don't know if you know it, the person who wrote that came back later in the Wall Street Journal many years later and said, I am so sorry. This was an error. It's my error. I hold it. But it was a terrible thing. And you had the inability to not give opioids to anyone who said they were hurting. And I remember, but as an anesthesiologist in Macon here now for 38 years, I remember meeting with the wonderful nurse who was tasked with looking at the responses, because you had to, as the pain is a vital sign, if the vital sign is abnormal, you've got to make an intervention, you've got to correct it, you've got to come back and see if the correction worked. And she had, like, for a weekend from the ER at our place, she had 150 patients who didn't get the level of relief that we said was mandatory for someone who had been given an intervention for their pain. And we had to figure out what to do about each of these that weren't. And so many of them were people who you couldn't have given them anymore. But we spent a lot of spent a lot of money and time and personnel costs and wasted time trying to figure this out instead of realizing we were on the wrong path. And shame on us for that. It's good to be better now than we were then. So one thing that's really influenced and changed what we do in the world of perioperative anesthesiology is came from a Danish surgeon. They started something called the Enhanced Recovery After Surgery Program, ERAS. And what this guy did was, he said, with the advent of minimally invasive surgical techniques like robotic techniques and whatnot, we can do surgery without as much tissue destruction and manipulation and problem. And if we do that, and if we do that quickly, we don't make the stimulus that causes the pain response last longer than it needs to, and we use the adjunctive medications. Someone asked about I think you asked about adjuncts to opioids that allow you to give less. we wrote the ones that we use at the medical center, and we bring people in and they get a non-steroidal drug like a Motrin or an Advil or whatever. They get Tylenol. They do get a gabapentin. The gabapentinoids have been found to be very useful. They're problematic in some of the elderly folks because they make them a little bit sleepy. We also have some drugs like clonidine, thought to be a blood pressure medicine, has I won't bore you with the effects, but a central effect on diminishing pain, as does a drug that's a little more modern called Precedex that we use very commonly. And we can do a lot of these, and Vanderbilt has done a ton of colon surgeries with no opioid given to the patient, pre-op, intra-op, or post-op. And one of the parts that has been most helpful for these programs' success is the use of perioperative blockade of nerves. We use local anesthetics to block nerves, and this has moved from, if you go way back, we found out, well, we can give you a slug of morphine and you don't have any pain. Great, okay, good. Well, there are problems with that. You can't go to the bathroom. You can't get up and walk around. Your blood pressure's down. So we started, and this was when I was a resident, we started using things like epidural opiates. And I remember the first guy I saw in 1985 who he'd had a pneumonectomy, had his entire lung removed. It was during the World Series. This is why I remember this. And we gave him 10 milligrams of epidural morphine, special preparation. And I went to check on him that night, and I went in, and he was in the ICU. Most of our patients who had to have a whole lung removed were on a ventilator for the first 3 or 4 days because they could not breathe because of the pain. And they would go into respiratory failure and die rather than breathe against the pain from an incision that typically in those days was from breastbone to backbone. And so I went in to see this guy, and he was in bed. He had the newspaper up like this. TV was mounted on the wall. When he heard something, he'd flip it down and look and flip it back up. And I said, and he looked at me, and I said, "I'm so sorry." He said, "Well, why are you sorry?" I said, "I was looking for Mr. So-and-so." He said, "It's me." I said, "That had a pneumonectomy today." He said, "Yeah, that's me." And he's sitting there pain-free, watching the ball game and holding a newspaper up with arms out like this, none of which would have been possible. So I said, "Okay, this is good. This is good stuff." And we were using epidurals for everything. It's like, if it's a good thing, everybody ought to get it, right? So we were using epidurals and epidural narcotics for all kinds of things. We found out that our doses were way off because we were giving way more than we needed to, and they scaled back over time. And we still use Duramorph, but now, for instance, instead of 10 milligrams, we might give 100 micrograms, a thousandth of what we were giving before, and find out, wow, that works well too. So we still do use epidural opioids, but then we moved from there because, again, you had problems with people who couldn't get up, who couldn't go to the bathroom, problems with their blood pressure because of the epidural medications. So we went to, let's go to focused nerve blocks. And so we got all kinds of ways. We use ultrasound. Anesthesiologists use ultrasound a dozen times a day now for nerve blocks or IV placements or whatever. But we found out that we could say you've had your elbow repaired. We could block the nerves up here. We didn't have much that was good for big truncal cases like hysterectomies or big open abdominal cases. Well, then the smart people came along with a block called the TAP block. Again, I won't bore you with what all that stands for, but you got 6 layers of fascia that invest the muscles of your abdominal wall. And between 2 of those specific layers is where the nerves run. And we can use ultrasound, see that layer, plant a little catheter right there in the layer, infiltrate it. And when we first started telling people this, we said, this will help with your pain, won't take it all away. Well, it takes about 80+% of their pain away. It's just ridiculous. And it's local anesthetic. There's no opioid to it. So it doesn't obviate the need for any other pain medicine, but it makes it where the need for those pain medicines is remarkably less. For things that are too high on the body to be gotten with that technique, we started doing a block posteriorly called the erector spinae plane block. That's another muscle group that invests a muscle, but also is where the nerves that come from the spine zip around to let you know you're hurting. So we can, same thing, we can isolate it with ultrasound. It takes less than 5 minutes. Put the catheter in, and we've got people who are very, very comfortable. Again, they don't have the constipation, they don't have the urinary retention, they don't have the blood pressure problems, they've just got the pain relief. So anesthesiologists have been working for a long time to develop these methodologies. It's interesting because someone asked our life care specialist about, do you get paid? Is there a way to get you paid? This year, we've been doing TAP blocks and erector spinae blocks for about 12 years. And in this year, the CMS announced that starting next year, they're going to pay something for these blocks that we've done absolutely gratis for the last 12 years. So that's an interesting thing. We've got a new thing that we're doing. I'll just tell you something I'm proud of right now. At the medical center, we're doing something with, we get about 300 broken hips a year. And I'm not talking about traumatically broken. We get a whole bunch of those too. But I'm talking about grandmama slipped, fell over the cat, tangled up in the cord, fell out of bed, whatever. The kind of the standard broken hip that we think about. Well, typically that patient comes in the hospital. They're in the ER. Unfortunately, they're in the ER a long time. They get a bunch of opioid pain medication. They get brought into the hospital. The surgeons are busy. Maybe they get them on the next day. Maybe it's the next. By this point, they've had a lot of opioids. They're confused. They're constipated. They get into problems from that. We take them to the operating room, put them to sleep, give them more opioids. They're worse. They can't go home. They need to go to an assisted living. They need to go to a rehab facility, or they got to have a sitter or something. And we said, what can we do better? There's got to be a way to do this better. So again, these same kind of space plane blocks. There's one in the lower abdomen, upper extremity called the fascia iliaca block. Please don't try to remember that. But it's another block that I can do in about 3 minutes with the patient lying in their position of comfort. It doesn't require anything. Don't have to give them any medication before I give it. Put the block in, their hip pain goes away. And it's gone for about 18 or 20 hours. We can get them on the schedule, hopefully the same day, bring them back to the operating room, do them with a regional technique like a spinal for their hip replacement, hip repair. And then they've still got the pain relief from this block. And now they're not confused, they're not constipated, they don't get those abdominal problems. They're more likely to be able to go to wherever they came to us from. If they were at home, maybe it's at home. We're trying to not have to escalate that level of care and not have people then who say, and older people don't do this near as much, but say, wow, that was a really good feeling, those pain medicines. I'd like to have a year's supply of that. So we don't have that much with the older people. But anyway, this is just another technique that stems from our ability to make the pain go away without opioid medications. You're going to see more and more of this. There's a drug coming out this year that is a drug that you'll actually wash through the wound before you close the wound, and the patient will have pain relief for about 4 or 5 weeks. It's like, what? And this cuts us out altogether. We're not even a part of that one. But there are new modalities, new medications, new pharmaceuticals that are coming out that are just wonderful. And so I think the more things that we do, that we can look a patient in the eye and say, no, we don't want to let you hurt. We're going to keep you from hurting with something different than opioid medications. we will start getting out of that trouble as a nation. So it's a tremendous amount of fun to do what I do in these days that we do it. We've got a lot more in our tool bag than we ever had before. And the drugs that get us in trouble, the fentanyls of the world, are actually really fantastic drugs when used appropriately. And Ted Stanley, who just died a couple of years ago, invented the entire fentanyl family. There's fentanyl, sufentanil, alfentanil, carfentanil, and carfentanil is a drug that's so potent that you could put it in an atomizer and spray it on the nose of a bull moose, and he's your best friend. He'll walk around and Ted had pictures of these moose drinking beer out of a bottle with their head under his arm, you know. Anyway, the things that can be done with these medications are just incredible when used appropriately. So I just read yesterday that the cartels in Mexico have now acquired the technology to make fentanyl by the ton. By the ton. Now, fentanyl is a drug we give in a microgram, 1,000 micrograms in a gram. We give it by the microgram, maybe 25, maybe 50 micrograms. And they are now going to have enough that you could essentially, you could kill our whole population with what they're going to be able to make in a day. So I don't know how we get all that part fixed, but I know that for the care of patients surgically, with anesthesiologists using the techniques that are coming along now, we can do an awful lot more than we used to do without giving people opioids at all. And I would love to talk more with you about it. I just didn't know how deep to go. Didn't want to bore you to death with it, but it is an exciting time. I'm excited for the life care specialists. I think that's the greatest thing I've heard today, is because we have a large orthotrauma component at our hospital, and you know, the pain that someone feels when they fell off a ladder is way different than the pain someone feels when they were in a car wreck because they were drinking and they killed their wife or their kid. Those things are too different. They can be the exact same X-ray of broken bones, but the pain experience is totally different for those people. And we need to be able to address that. And it's not getting addressed on rounds when these guys are seeing 40 patients in the hospital and trying to get in the operating room by 7:15. So, kudos. If you want another place to, we can talk. I mean, but I would love to answer any questions you have, or if you want me to go deeper on something, whatever.
Thank you so much, Dr. Lane. We have had some really great information this morning, I think, but that is so exciting, just to realize the possibility and potentials that are coming along and increasing to not even have to have those really tough pain medications that are tough on everyone in different ways.
They are.
Yeah.
They are. Well, thank you.
Yeah, so thank you. So let's see if there are any questions. If y'all would do, Justin did a great job last time, so I think if you'll raise your hand, we'll get him to load you up. I think you're ready. Yeah. Just talk.
Got it. Thank you so much for your presentation. I'm Sharon Cooper, Chair of the Public Health Committee in the Georgia House. You probably know who I am.
Yes,
I
do.
See a lot of y'all. I have a question, two questions, but first of all, one is just for personal information. Are you a Georgia boy?
Oh, yes. Yes.
Okay.
I grew up in Dallas, Georgia, northwest of Atlanta. Used to go play golf with my dad and a guy named Nathan Deal up there, who was a forever member of the House. But anyway, yes.
Okay. The reason I ask is, thank you very much for practicing medicine in Georgia. I don't know whether you went away to medical school or residency, but thank you for coming home. We have too few doctors. Okay. Usually disseminating new ideas through medicine used to be 17 years before it would get through. It's much shorter now because of ALS, but I want to know what you're talking about. Is this your group to just practicing together and you talk about all the new things? Or do y'all come together here in Macon, the orthopedists, and talk about them? How is this getting disseminated out to Georgia doctors about these new things?
What a great question. And I wish I had a really cool answer that told you how we got it done and it's working marvelously, but I don't. What you're referring to goes all the way back to the work of Semmelweis, who a scientist who found out that if he would quit going to examine women who had just had a baby after coming from the morgue where he had been doing autopsies, if he would just wash his hands first. And that sounds so ridiculous now, but at the time, they put him in an insane asylum because he was trying to get people to wash their hands before they touched patients. And his patients were dying at about a 20th the rate of these other guys' patients. You'd think everybody would have said, man, Semmelweis, what are you doing so we can do the same thing? Instead, they put him away. And it was, as you said, almost 20 years before everybody said, yeah, that guy was kind of onto something. Let's start washing our hands. To us, it sounds so stupid. Something we're doing today is just as stupid. We just don't know what it is yet. Maybe we'll be talking about how we used to just give these people opiates and snow them down. How crazy! But yeah, what it started at the medical center with discussions on length of stay. Hospitals are being squeezed. Everybody's being squeezed. Nobody wants to pay as much, and I understand that. So they said, how do we get these people out of the hospital? How can we get them from having to go from getting up to find the TV remote to go into a nursing home because they've had a broken hip? How do we stop that? How do we get them out of the hospital quicker? And that's where they did. We brought orthopedists and anesthesiologists together and good nursing staffs and talked about the best way to do this. And that's where we sort of came up with that. We're doing the same thing. We're trying to alter the way we do our cesarean section anesthetics that are going to we think will get women out of the hospital one day earlier, if they desire to do so. Some don't. If they've got 3 kids at home being taken care of by somebody else, they're really happy to stay in the hospital that extra day. But anyway, so it's been looking at things like length of stay. Now the problem is what I alluded to, and I kind of gave it short shrift that said, we did these blocks for 14 years and we didn't get paid for them. There are a lot of people out there who say, yeah, if I'm not going to get paid for it, I'm not going to do it.
Okay.
And we're not getting paid. The thing we're doing for our hip fracture patients, we're not getting paid for that. But what we are doing is we're saving a lot of money on the backside, for the hospital. And for my group, which is a contracted group with the hospital, everything is not money. The fact that the hospital will say, we're going to keep Bob and his group because they've saved us money over here. That's plenty for me, thank you. That security that we get because they can't do it the same thing they were doing without us. Now, the American Society of Anesthesiologists will have their meeting this year in Philadelphia in about 4 weeks, and I'll be there, and all these kinds of things. There'll be people talking about these things, and I'll learn things, hopefully, that I don't know already, and bring them back and start disseminating them and trying to get people to put them into practice. But somebody said in a lecture a long time ago to me, the greatest impediment to change is 20 years past experience. And I've lived my career trying not to be that guy that wouldn't change. I want to embrace the change if I can.
Thank you.
Yes, sir.
Yes, sir. Good morning. Michael Pursley, Chief of Police in Albany, Georgia. To piggyback on what she was saying, I got 2 questions. By saying that 20 years from now we'll figure out, that's what we should have done, what are some other techniques that are done by other physicians, anesthesiologists, or even in foreign countries that may be barriers or areas of concern that our U.S. medical group or others connected to it may have objections against using them?
It's really funny because what you're hitting on are the cultural differences in how things are perceived. And I had a friend who was from Jordan, and he was an OBGYN in Jordan, and when they introduced epidurals into the hospital there, the big hospital there, the mothers of the patients were very upset because in their culture, screaming through labor had to happen. You had to happen. And so Ibi, this guy's name was Ibrahim, he went by Ibi. Ibi said that the mothers would stand next to the patients and pinch their faces until they screamed. Because you got to scream if you're having a baby. Now that sounds silly to us, but it wasn't silly to them. It was how it was done in that culture. So they weren't happy about the fact that they had pain relief for labor. There are some cultures who think that pain relief for labor runs contrary to the will of God. You got a lot of barriers to overcome. I remember an Egyptian colleague told me I had put an epidural in his patient back when that was what we did, and the guy was pain-free in the recovery room, but he was not happy. And he said what he wants is for you to load up a bunch of painful to inject medicine on a really big needle and plug him in the rear end with it and make his head feel funny. He said that's what he wants, and it was. Ultimately, I wound up taking the epidural out and doing that thing because I was giving him what was the best, but what he wanted was what he had always been told you got at the hospital, which was a big shot that hurts and then your head feels funny. So I think as we educate, all these things are overcome by education.
Mm-hmm.
And I think as we educate people that we can do better with different medicines, with lower doses of medicines. Like I say, you know, in an effort to make sure what we did worked, we give too much, and then we slowly find that we can really back down to here, and we have something that doesn't cause nearly the side effects and still is efficacious for pain relief. So, but it's a tough question. It's a good question.
Okay. And a comment, then my last question. My comment is, I think that in an approach to have a fast and quick way to recover from pain, we've developed unintended consequences of substance use disorder. Mm-hmm. My comment, I don't want to get nobody in trouble. My question is, you mentioned an article where a guy later refuted, I guess, apologized. What was that article and who was that person again?
Oh, I wish I could remember his name. The original article, Pain is the Fifth Vital Sign, probably came out in the early mid-90s, something like that, and it took off. It was everywhere. You couldn't get away from it. And then when the underlying premise, and I didn't give this earlier, the underlying premise was that people who have pain do not become addicted to pain medicine. That the only people that get addicted to pain medicine are people who use pain medicines recreationally. And that was his premise. And he had a lot of data. And it looked like a good paper. But it was wrong. And isn't that such a shame? But it was wrong. And because people who have legitimate pain can get addicted to pain medicine. They don't with the same frequency, but they can. And nothing makes that more likely than unfettered, unrestrained use of pain medication beyond the time it's needed. I'll give you one really quick thing on how different people are. One of my partners, in fact, the practice partner who came in so I could come in here to talk to y'all today, he had a 2-level lumbar fusion a year ago. He had it on a Thursday. He was in so much pain before he had it, and he didn't take any pain medicine in the recovery room. He called me the following Tuesday. So he had it on Thursday, calls me the next Tuesday. He's almost in tears. I want to come back to work. I feel so good. I feel better than I felt the last 10 weeks at work. Why do I have to stay here? I want to come back to work. I said, talk to your spine surgeon. Talked to the spine surgeon, said, yeah, let him come to work as long as he maintains the prohibitions against not lifting more than that or twisting this way or that way. So this guy never took a pain medicine in the recovery room, never took a pain medicine after he left the hospital, never took a pain medicine. None. At the same time, the surgeon told me that he had a guy who had had the exact same operation, done by the same surgeon in the hospital the same way, that 6 months later came to his office. He was still requiring 6 Lortab a day. He still couldn't go back to work. He still couldn't do anything. He still said he wasn't sleeping. So people are just cut differently. We're all made a little bit differently. And there are some things that are motivators to make people not let go of that pain. If they're going to have a big workman comp settlement, if they don't let go of the pain, it's easier for them to hold on to the pain than if they would work for themselves. But we're just all really cut differently.
Thank you, sir.
Yeah, man, thank you. Yes, sir.
Thank you for the presentation, Dr. Lane. I'm Alan Wong, internist, hospitalist, pain physician. And first a comment, then a question. This ties in a little bit, Chief Persley's comment and your comment about your colleague from the Middle East. But, you know, our country has about a healthcare cost of GDP 17%. It's the highest in the world, always has been. And right now, I think 5-6% ahead of France, who's in a distant second place. Bottom line, we have a very costly healthcare system. We know that, and there are different things that contribute to that. Certainly, unnecessary procedures. You talked about all the different new innovative techniques, which are great in anesthesia. I know you deal with a lot of surgeons, and so I think the comment really is, we have a lot of these unnecessary procedures. We should be having more of a focus on prevention, alternatives, et cetera, and using pain as a last option, which many other countries do procedures as a last option, should be a renewed focus. And by doing that, your job also becomes easier, and therefore, we don't have as many people, tying it back to this committee, in the need for pain pills for post-operative procedures, et cetera. So that's just one comment. The question I have for you, last time when we met, we had somebody from the DPH speak with us and showed us some numbers related to the PDMP program. And I think it's been 6 or 7 years it's been around now, and it showed about a total of about a 10% decrease in opioid prescriptions, which is not bad. I think my prescription habits have changed dramatically. It's a lot more than that, so I was kind of surprised to see that 10%. Nationally, I think they showed some stats. I don't know how accurate it was, but it was 20-some, maybe 20-some%. So my question to you is, what can we do as physicians in this state, or what do we need to make a bigger dent other than 10% through what to me was a very good program and still is, but how can we make a bigger dent in dropping that, doubling, tripling, quadrupling the amount of prescription opioids that we write for?
I think it's, I can't read the name from here. This gentleman who said earlier that in medical school we bombed everybody with antibiotics. And I have a son who's a pediatrician in Augusta, and the most unhappy patients he deals with are those people for whom he says, no, an antibiotic is not indicated here. And what you're starting to see now, finally, with opioids is the same thing. No, I'm sorry, we're not going to be able to give you a bunch of opioids for this. I think at one time it was 98%. It may be down now to 96% of the world use of opioid medications occurs in this country.
That's right.
Do we think the rest of the world is writhing in pain? Are we the only people that hurt? Or does it have to do with how many interventions we do on our people? When and I've been in Macon a long time, and I like Macon. But just take this with the humor I intended. But when I was in Augusta at the medical college, and they said, "You got a job?" Yeah, I said, "I'm going to Macon." They said, "Wow, you better learn to sleep on your back. If you sleep on your stomach, somebody will cut your back in Macon while you're asleep." And it was our utilization of spine surgery in Macon is notable nationwide. We operate on a lot of backs here, and I mess with some of my surgeons about it. I say, man, you did a bunch of good operations today. A couple of them were even indicated. We have to figure out that not everybody has to have an operation before they die, and we need to be more judicious in our use of things. If you have a procedure that 30% of the people get better, 30% of the people get worse, and 30% of the people stay the same, I don't think that's a very good reason to have an operation in general. And specific cases can be different. Obviously, my partner that couldn't walk, who then never took a pain medicine after his surgery, his was a well-chosen operation. But yes, we've got to find a way to get that number on down. It is an amazing thing, though, the effect that the Hawthorne effect, when we examine behavior, the behavior changes. And I think it may be that we start having to say, okay, guys, here's Dr. Lane's use of opioid medication versus him, like we do some other things. There should be nothing wrong with putting the truth out. Yes, sir.
Yes, thank you for your presentation. You've mentioned, that people are cut differently and that dosing, I guess there used to be more prevalent overdosing, but not overdosing in the sense of, but being prescribed too much of something. So what is being done to improve the dosing that, I guess what's being done to improve dosing? What else can be done to further improve it? Where do you see this going? Because I suspect that a lot of addiction stems from being prescribed too much.
Absolutely. It's a great question. I think education is the answer. It seems like education is the answer to most of these things. But you know, I remember an old orthopedist when I was working with him on a Saturday, and somebody called and he said, I give everybody 40 pills and 2 refills, and because I don't want any phone calls. Well, that's kind of a short-sighted way of looking at it. And you know, he didn't realize the problems people were getting into with his 120 pills. And I think that in general, as we teach people in medical school, you know, we need to be teaching for a goal of maybe 10 tablets. If you're still having problems, come back and let's see me. Let's talk. Let's find out why you're hurting. Again, getting back to the previous presentation, maybe there's more going on there. Maybe there's something else happening in your life that's making you have to have this. I think we're going to have to get there. We're going to have to get there, and not be giving people so much medicine that they've got tons of it laying around the house. And if you got anything laying around the house, get rid of it, because people come in. You know, if you have a party at your house, somebody's going to get in the medicine cabinet. You can almost count on it. You got to watch. You just have to watch, because there are people that are in trouble everywhere.
I think we have one more. Chairman Cooper, maybe.
I have a couple. All right, the procedure you're doing where you go in between the layers of muscle.
Mm-hmm.
All right, can you do that in an outpatient? Could you start treating some of this pain that way?
Well, it's interesting because most of what I've been talking about were for post-surgical pain, not chronic pain. Now, I wanted to bring my chronic pain guy with me, but we couldn't get both of us out of the hospital at the same time. But there are a lot of interventions that the chronic pain guys are using as well. There are some cryoablative therapies that are just crazy good. I just can't believe it. You can go 3 days before your knee replacement, get the genicular nerves denervated with cryotherapy, go have your knee replacement, and never have pain from it. It's just crazy.
But chronic pain, like from, our elderly population, which uses quite a bit, I mean, not as much on a regular long-term basis. It's one of the things we heard when we went to the PDMP was, what am I going to do about, from the orthopedist, my little old ladies who take one opioid pill a night to be able to sleep because they got arthritis so badly. Can you do some of these new things if you're just running an orthopedist or that calls in an anesthesiologist or somebody that's just running a routine practice, not before surgery or anything like that?
Yeah, there are things that can be done. You have to be careful. Some of the things that we do also cause motor blockade. You can't get somebody up ambulating and have them fall down and break the other hip. That's bad form. But yeah, we can. There are things that can be done as an outpatient that are useful for those patients. Okay. And it's funny, I love elder tonic, not personally, but you get these little people that would never drink. Lips that touch liquor will never touch mine, that kind of thing. But they'll take the elder tonic because it's medicine, which is really like a really good sherry drink before bed, and it improves their appetite and it helps them sleep too. So there are some useful things that can be done.
And I think that we have a society, especially now, which is beginning to be a problem, who wants to feel no pain. Never. We're raising kids that we don't let them have a wreck on their tricycle or put the helmet on. We don't want anything to happen to us, so we don't get used to the fact that you can break an arm or something as a kid and you can survive without pain medication. But the other thing is, have the hospitals. Is it still a really usual thing where the hospitals get dinged? Are they still giving the patients the surveys, and if they say they the hospital didn't meet their needs, they didn't take care of their pain, they get dinged money-wise from Medicare.
They are. I think some of that is scaled back since we've realized that the pain's not really the fifth vital sign. Some of that's gone away. But yeah, the HCAHPS, the patient satisfaction scores, people live and die by their HCAHPS scores. And all you got to do is not bring somebody a Coca-Cola when they ask for one, and they can blow your whole hospital out of the water with their rating. And it is a problem.
So when they trying to, especially on narcotics, trying to reduce a major problem, and then somebody just didn't get exactly what they wanted or named a drug they wanted, and they can cause trouble. It really is working against some of the things we're
One of
trying
my
to
big
do.
roles at the hospital is they send me in to be the guy who says no. Because they say, we're going to send you a pain guy in, and whatever he says is going to go. And I say, okay, and I go in and say, no, we're not giving you more pain medicine. And they say, well, you can't discharge me without it. I said, yeah, we can. Well, I'm sorry. Yeah. Sorry you're hurting. The idea somebody mentioned about outpatient pain clinics, it's a wonderful thing. The problem is, again, gets back to remuneration. These patients who are Medicaid or no pay are not going to get in a pain clinic.
Okay.
They're not going to get in one. And it's just the facts. It's troubling, but it's a fact. Thank y'all very much for letting me be here with you.
Thank you. I will tell you that you should sleep well tonight, because I think you have planted a lot of great information in our minds, but also I think just personally, some personal knowledge for those of us who might not be physicians or nurses, who also, and who are listening out there in the world beyond here, to realize that there are some amazing alternatives. As the advocate for yourself, sometimes you have to ask those questions, though. So, thank you so much.
Thank you. All right, y'all take care.
All right. So, that is our last presenter before lunch. We're going to take a little break here. I want to tell the committee, make sure you're aware that as we go out the door, if you go straight that way, there are men's and ladies' rooms. Lunch is ready outside, and there is plenty. If everyone would let the committee go first, just so that we're sure that we have all had our first look at what is out there to be ready for this afternoon. Y'all, I am so thrilled about the information we've received today, and I look forward, because Morgan has done a great job of putting more presenters for us, and I thank Mercer. How appropriate is an umbrella today, of course. That couldn't be even better. But also, they are being such wonderful hosts, their hospitality for the breakfast this morning and also for lunch. So make sure to say thank you, and I'll recognize them again before we adjourn. So enjoy the break, and we will be back. Well, good afternoon. We're glad to be back with you. So we've had a great morning, but now we're going to hear a little bit more, 2 more speakers this afternoon. And our first is going to be Dr. Catherine Cheek with the Medical Association of Georgia. And Dr. Cheek, when you come up to the podium, if you would tell us a little bit about yourself too. And thank you for being here.
I'm Catherine Cheek, and I currently live in Butler, Georgia, but I'm have practiced my whole medical career in Columbus, Georgia. I'm a pediatrician by training. I grew up in North Carolina, went to the University of North Carolina, but moved to Augusta, Georgia to work right after UNC, and have been in Georgia ever since. So my medical training was at MCG. I did my residency training at Emory Grady, Chief Resident Pediatrics. Enjoyed every minute of that and have loved all my moments of being in Georgia. That's where I met my husband, my family's here, and so I'm glad. I think MCG, although I was not out of state at that time, has gotten their money out of me in terms of being a physician. I just retired as of January 1 of this year, and I am currently on the Composite State Medical Board, and that's really, MAG asked me to come and be representative to you based on that. So I'm really in here on behalf of the Composite State Medical Board and want to answer all your questions. I am relatively new to the Composite State Medical Board. I am vice chair, probably been on it 3 or 4 years, but there's a lot of other people that have been on it a lot longer than myself, and I'm assuming we just do integrate. I wanted to say a couple of things. First of all, Chairperson, Chair Lady Dempsey, thank you so much for this opportunity, and all the other distinguished members of your committee for this opportunity. Not only the opportunity to present for you today, but also to say thank you. You did, to the Composite State Medical Board, give us more money, which was greatly needed. You also passed state raises for our employees, which makes us easier to hire people. So I would be totally amiss if I did not say thank you. We still need more money, I'm sure, as every other state agency comes before you, but I did not want to miss this opportunity to say thank you for that. I did want you to understand that we license lots of professionals, not only physicians. Of course, physicians are the largest group of the ones that we license. And I am chair of the APRN committee that reviews the protocols. We got down to 1 staff member who was, helping us. And so we're now up to 2. We used to have 3, and we need 4 or 5. And so I know all of y'all have had complaints to your offices about the Composite State Board, sometimes the turnaround on licenses or APRNs or PAs. We're trying. We do have a new executive director, which if you haven't met, I'm sure you will meet on the Hill, and he will introduce himself. His name is Jason Jones. He's doing a great job. He's only been there about 6 months, has made tremendous changes, and we are getting a new software system, again, thanks to the budget coming in January. So we all think it's going to be a much smoother transition as we try to license people across the state of Georgia. So there is hope, even though you've had some complaints. We would encourage you to call members of the Composite State Medical Board if there's somebody in your district that's really having a problem getting licensed and you want us to look into it individually. Things do get lost in the system. Southern Bell or whatever telephone company we use, sometimes they have the phones routed in the wrong direction. You know how this works. So anyway, if you have a problem, please contact a person that you know on the Composite State Board, and we can help you. We definitely can. Before I go just a tiny bit further, I wanted to ask, I put together this presentation, but also another presentation on just Schedule 1, 2, 3, 4, 5 drugs. I wanted to make sure that everybody understands that, and if that's something that you've already had presented, it's only 5 slides. If I could just go over the scheduling of drugs so you know what I'm talking about, if you wouldn't mind pulling up that other PowerPoint, because this is something like I sometimes have to refresh myself going, okay, is this a Schedule 2 or a 3? You know, so I just wanted you to know what that was. Okay, so just so you'll know about scheduled drugs. Schedule 1, we're going to talk about, is examples of heroin, marijuana, ecstasy, peyote. All those are very hallucinatory drugs. And marijuana is still listed as a Schedule 1 drug on the federal state registry, despite the fact that it is, you know, legal in lots of places. So I just want you to know that. If you want to ask my personal opinion about legalization of marijuana, we can talk about that later on, but I just wanted you to know where it stood. This is the most dangerous, level 1 is the most dangerous drugs that we have out there in our armamentarium. Level 2 examples are cocaine, methamphetamine, oxycodone, fentanyl, Adderall, and Ritalin. And you know how prevalent these are in our communities and across our state. And that's the second highest level, okay? Level 3 is ketamines, anabolic steroids, testosterone, and products containing less than 90 milligrams of codeine. Ketamine, you're going to hear a lot about ketamine, I'm sure, in the coming legislative season. We're just in the process of trying to get the rules and regulations around ketamine administration. You can think about Matthew Perry. You know, we've got to be very careful with this drug, even the fact that our anesthesiologists and other people know that it's a very, you know, wonderful drug in lots of uses, but it doesn't need to be in everybody's backyard armamentarium to go get for your headache, okay? That's my personal opinion. Schedule 4 are Xanax, Valium, Ativan, Ambien, and Tramadol. Tramadol is a medicine that, you know, is an opioid that we use more frequently as an alternative to an opioid because it's less addictive, okay? And Schedule 5s are drugs like Robitussin AC, okay? So just from beginning to end, that's kind of where they all are, okay? But I didn't know if you'd already had that presented to you because it tells you, you know, what's at what level and kind of who's the scariest out there, okay? So I just want you to see that, and if you'll help me get my other slideshow back up, and I'll answer any questions about the Schedule 1, 2, and 3 if you want to know about that, or you can save those to the end. And I'll tell you about some things about that. Okay, thank you. Uh-huh.
Are doctors allowed to order Schedule 1s? No. No.
Schedule 1, like hair, no.
No, they don't.
Now, you know, there is the where you can, there are medical indications for marijuana, you know, in terms of the oil of marijuana, and, you know, we have a whole thing through Department of Public Health
Yes,
that you can have medical, you know, medical marijuana prescriptions. I was just in the office 2 days ago. We had our public health meeting, and they said that they are printing 1,000 of the little cards for medical marijuana a month. I think is what they told me, for people with, you know, physicians and that kind of thing. So just know that that certainly is out there, and I'll correct myself if I'm wrong, but I'm almost positive they said 1,000 a month of the cards, so it's legal for you to have a certain amount to carry with you for medical reasons. And
yeah,
so,
we have different opinions on that too.
Okay.
Yeah, okay. But I was just making sure, in 2s, we did restrict the use of the ones they use with kids so much on the 2s. Physicians can order them, but PAs and nurse practitioners can't, right?
That's right.
Okay.
That's right.
All right. To try, because they were being so overused. If I remember, that's what we did.
Yes,
Okay.
that's correct. Okay.
Question as well. Is the schedule ever updated? Like, one thing that stuck out to me was Xanax, Valium, and drugs of that nature being scheduled for, deemed like I forgot the exact phraseology, but like low possibility of abuse? Because I think of those drugs as being pretty widely abused. So I'm curious, like, if
This
those
schedule
schedules are ever reviewed.
This schedule is from the federal government, and I honestly am not familiar with how that's just where it is. That's where it came from I don't know how long ago. It's been out there since I was in medical school. So I don't know who reviews that. I think as far as medicine and just, the potential for abuse of all kinds of drugs, people are more aware of it, but I don't know that they're interested in changing the schedules at this point in time. And I think it's based on just I guess the anatomics of the different drugs and the preparations that are out there.
The feds do send us updates when things change. Y'all remember them? And usually Butch will go and say, this is the update, so we match our drugs to whatever level they are to match the federal level. But obviously, since we restricted on the Schedule 2s who could order them, we do have some ability to restrict people's ability to use them. Like I said, physicians can order the stimulants like for hyperactive children and stuff, but PAs and nurse practitioners can't because we put that in a state law.
And I do think it's interesting that Schedule 5 is still, marijuana is still in the Federal Registry as that, despite the fact it's legal in states. So anyway, just that's a whole nother topic.
But it's known that the feds could come in and close them down at any time. I mean, when they passed the bills, people were telling us that we can pass that, but if the feds want to enforce the fact that it's still a level 1, they could close down the pain clinics, they could close down the people that are manufacturing at a drop of a hat.
They still regulate interstate travel.
Right.
Of marijuana.
And remember, we said tobacco was safe a long time ago. And where would that take us? So anyway, I probably shouldn't have said that, but anyway. Let's talk about the requirements for continuing medical educations of physicians. Basically, as a physician, we're all required to have 40 hours of CME every 2 years license. We get licensed every 2 years, so basically every 20 years, every year we have to have 20 hours. In 2018, the legislature said we have to have 3 hours of opioid prescribing education if you have a DEA, and so that's been present in our medical education requirement since 2018 from the state legislature. Just of interest, 2 hours have to be in professional boundaries, and then just recently in June of 2023, the DEA has required an additional 8 hours if you have a DEA of education in opioid use. So lots is happening in the regulatory world to help all of us physicians be better informed. And in this 40 hours of CEE, let's see here, there we go, let me get one more. We have to have appropriate understanding of how to prescribe it, how to prescribe the types of abuse and how to deal with abuse, and also the misuse of opioids in our communities, and understand the guidelines for pain management. And I wanted to show you some of the accepted courses, but really the best thing that has been done with the DEA and then also the requirement for the state is that it's really in your specialty that you can get these opioid management courses. So for me as a pediatrician, I can get them through the American Academy of Pediatrics, and that's specific to what I'm dealing with every day. It's not just a general course versus like, an anesthesiologist got a place to go get their CME requirements. So in terms of documentation, you have to keep that as a record, just like you have to keep all your other CMEs as a record. You're really not required to present that to the board unless you get in trouble or call for an inquiry, and then when you come for an inquiry to see us or have a meeting or an interview, you're required to bring all of these documents with you. So pretty much everybody knows that they have to do this.
Did you say 8 hours? DEA 8 hours?
DEA has an 8-hour course starting in, the requirement was just instituted in the end of 2003. But so on your next license schedule, you have to.
23.
Uh-huh.
Yeah, 23. Okay.
23. But
So that's new, the 8 hours, that's a lot of hours.
Yes,
Good.
sir. But it is required in order to be able to get your license in Georgia and to get your DEA renewed.
Okay, can
Okay.
I say, I have a question. Okay, I think I'm the one that moved that bill that made the first requirements. And no board likes to have a mandate of anything, because they'll say, oh, well, you're going to mandate training on ethics and mandate all of this. With the 8 hours that's now required by DEA, should we go back and rescind those other 3 hours?
Most people have already gotten the other 3 hours because, we get licensed every 2 years. So
Right.
you've probably already done your 3 hours. And I would think that the 8 hours, if you're new, is going to cover that. So,
But should we leave it on the books, or should try to take it off, or just let the new people take that and the 8-hour one too?
I could ask if our rules committee at the Composite State Board, probably I would say that if you have the 8 hours, that's going to count as your 3 too.
Oh, y'all are going to count it as the 3, okay.
So I wouldn't bother taking it
Yeah,
off.
okay, all right.
So is the federal 8 hours biennially? No, it's every 2 years you're going to have to, every 2 years you're going to have
No,
to
it's
have-
going to,
It's a one-time 8 hour, isn't it?
One-time 8 hours.
So
uh-huh.
the 3 hours going to continue, ad nauseum for y'all, just
No,
like it
that's
does
a
for
1 hour
dentists.
requirement also. I mean, a one-time requirement also,
Yeah.
one-time
It's
requirement.
only one time. And what she's saying is that it's no use in rescinding it. If they do the 8 hours, they'll count the hours.
Right,
It
right,
means
right.
ours too.
So,
That's a
Georgia and the
one-time,
state
though.
was ahead of
Okay.
the FDA, basically.
I thought you
Okay,
meant
for the-
every 2 years you had to do 8 hours, and that's why I'm going, wow, that's a
Well, no,
lot.
that'd be a lot.
Yeah.
Okay. So that's our CME requirements for the state board. And I'm going to move on, and we can still answer me questions about that going forward. But I did want to speak about the Pain Management Act, because I guess y'all all know about this in the state legislature. This was actually put into place in 2013. And these are pain management clinics in Georgia. And basically any clinic that has more than 50% of their patients are chronic pain patients managing their pain, then they're determined a Pain Management Act, and they have different requirements under the law to fulfill, and I'm going to go over some of those with you about these pain management clinics. They are monitored and regulated by the Composite State Medical Board. So you must be licensed, of course, by the Composite State Board. You must register with the Georgia Department of Public Health. You must have a Georgia licensed physician as the owner or designated physician, and it cannot be owned by people who have been convicted of a felony, other violations of controlled substance, or other controlled substances. The medical rector must be a licensed physician. That person is responsible for compliance with state regulations, including prescribing practices and patient care standards. They have to be board certified or board eligible in a pain management or related field, and they must follow specific guidelines about opioid prescribing and have protocols for monitoring controlled substances, doing drug screens in their clinics, making sure patients are not taking more than whatever they've been prescribed for them. They must have these treatment plans. They must maintain proper storage. They must participate with the PDMP and are required to look at that over all their patients. And I will go over the PDMP. I know you've had some information about that, but I have a little bit more for you. They are subject to inspections by the Georgia Composite Medical Board or other agencies, and they have been inspected, and some of them have been closed down. Based on complaints, there's been some criminal investigations into some of these. But basically, they were required to maintain records of their patients' treatments and controlled substances. They must renew their license and submit all these reports every 2 years. They must demonstrate ongoing compliance with the regulations. They're restricted on their advertising, and the staff must have appropriate qualifications, training, and certifications. As you can imagine, when this was put into law, this a lot of pages of regulations. But bottom line is, I tried to summarize this for you to let you know that there are requirements of these pain management clinics, even though they're out there, and if they're acting legally, they have to be renewed every 2 years. So, just so you'll know that. Yes.
Just a quick clarification on the initial slide. So if it's connected to a hospital or a skilled nursing facility, some type of healthcare entity, this does not pertain?
That's correct.
Okay.
Okay.
Thank you.
Okay. The PDMP, which they utilize and all the physicians utilize or can utilize, these are the same slides I think you saw a couple weeks ago. Dr. Rushkin and Commissioner Toomey put these slides together and allowed me to share them with you again today. Basically started in 2017. You know, we were actually, I think, the 9th or 10th state to institute a PDMP. Very proud of that. Most of the time we're down in the 40s and 50s, so for those legislators that moved that forward. I think, all of but one state, and that state is Missouri, has a PDMP, and for whatever reason, Missouri does not have one. We currently share data with the PDMP with 19 other states, and are moving towards trying to get the other 49 and the District of Columbia, I guess, where we share data with them as well too. So not only am I looking up, when I look up the patient to see if they've received a narcotic in Georgia, I can tell in the other states, especially our surrounding states, if they've received narcotics. So this is a very important tool that's in our belt that we use every day if you're prescribing narcotics for patients. And you'll see that basically if you are using Scheduled II drugs and above, you certainly have to look this up. Let's see here. There are some exceptions to the fact that you have to look this up, because if you are looking it up, you have to put it in the patient's record that you documented that you have reviewed the PDMP within 24 hours after your prescription. The prescriptions that are not required to be looked up, if it's only a 3-day supply and no more than 26 pills, and this has been a good thing because that has encouraged a lot of patients to do that, making sure that they're given much smaller prescriptions because they don't have to go to the trouble to look up the patient. If the patient's in a healthcare facility such as a hospital, nursing home, immediate care home, personal care home, which provide care and prescriptions to be administered to the patients on the premises, you don't have to look it up. So if you're in the hospital, you're not having to look that up because you've got control over what the patient's getting. An ambulatory surgery center, no more than a 10-day supply, no more than 40 pills. Again, this cuts down on the number of pills the patient gets. And of course, if the patient is terminally ill or in hospice care or receiving treatment for cancer, these are exceptions to the law. The number of pharmacies entering prescriptions in the PDMP, and you'll see this is opioids and stimulants and benzodiazepines, just based on the pictures. But what you'll notice that there's not that much increase, mainly because pharmacies, were initiated at the very beginning. They had to get on board with this and get online. So there's probably a reason it's not dramatically up is because everybody sort of got on board from the very beginning when this law was first instituted. You'll see that the number of provider inquiries, the number of people looking up things is actually going up. So that's a good thing. People are doing what they're supposed to under the law. And then the prescribing trends, I think y'all mentioned this before. This is the decreases that we've seen in the number of opioid prescriptions. And all of those are good numbers up there. So I think, we'll see more and more as time goes on. Remember, this is just through 2023, and so we'll have more data as time goes by to present to you on this. anyway, I wanted to say that was the end of my presentation. Thank you so much for trying to provide quality, making sure that we're providing quality medical care to all of our constituents of Georgia. But most importantly, since I'm a pediatrician, most importantly, thank you for really helping protect the future and our Georgia's best natural resource, our kids, and that's who you're really doing all this for, I hope. So I just appreciate your hard work and the things that you've done, and I'll be glad to answer any other questions about the Composite State Board that I can. Oh, yes, sir.
Do you know Ben Cheek?
Vaguely. No, he's my husband.
I sort of figured that. Tell Ben that Lee Hawkins said hello. He and I went to Georgia together, SCs together.
Okay.
And I see him at the Capitol quite a bit.
I was telling someone earlier, Ben, my husband, enjoys the legislative process and likes to come to the Capitol to see all of y'all, and so many of you probably know him from that aspect. His dad was in the state legislature. I think that's how he got the bug way back when. He's much better at this legislative things than I am. But
he is good.
We'll be glad to tell him hello.
Yeah, thank you. Thank you.
Is there another? Yeah.
Dr. Cheek, thank you for your presentation. I had a question relating to the medical board. I think twice in the last year has looked at kind of rescinding or moving back some of the telehealth flexibilities that were put in place related to the pandemic. I think that's back on the drawing board right now, and I believe one of the reasons that they were looking at reinstating the 72-hour rule, which was to look at opioid use disorders. Can you shed a little bit of light about what the board's thinking is on that and what that's liable to look like when it comes back out at the end of the year?
Well, the reason that we went back on it is because the federal government went back and maintained the pandemic rules. And we really, as a state, did not want to just have people confused about what they could do. And, the state right next to us is doing something different. So we're really waiting to see what will come out from the feds in terms of whether or not these rules will be rolled back. I think the American public has gotten very used to telemedicine, and so we're not going to be able to totally restrict it in terms of it just goes away. That's not going to happen. The public is too used to that. But we do want to be very careful to make sure that some person, out of our state is prescribing very differently than the physicians in our state. So I think it's just a little bit of a wait and see exactly what the feds come down with, and then we'll make our decisions of how we want to proceed forward. I think it will be a little different than it was pre-COVID, but I don't think it'll be wide open, that we'll just let everybody and anybody from any country or state prescribe in our state is probably not going to happen, knowing the sentiment of the board. I know that's kind of a vague answer, but it is sort of vague until we see what the feds are going to do.
Thank you.
Mm-hmm.
I was at the Emory Addiction Center for the Emory University, I think yesterday or whatever, sometime this week. And they are lucky. They have 4 physicians that are trained, 1 pediatrics and juvenile and 3 for the others on addiction. But we don't have that across our state. And they are saying that they have been able to very effectively work with people addicted by telemedicine. And so they certainly, and it is very different. It's not like having a physical illness and, our requirement that you have to see them first and this kind of thing. So with addiction, I guess they would certainly like consideration for the different kind of practice that is with psychiatry and all.
And lots of mental health, not just addiction issues, has been successfully treated through, and it's so much nicer for the families. And, I did a lot of telehealth during COVID, and I think it is different. You can't examine the kid, but something, you get to see the environment that they're living in and that family's in. And sometimes that's just almost as insightful and intuitive as putting your hands on them, because you see the situation that grandmother or their mother or that poor kid is living in. And I think it has been a very valuable additional tool in our ability to help patients. I do think, however, there are some, and you see them online. You just basically call up. You don't even have to talk to the doctor, or you can talk to the doctor, but you don't have to answer any, hard questions. And I'll send you a prescription for X. We just can't have that for opioids and stimulants and all those other scheduled drugs. That just can't be. So we can't make it too easy.
Right.
But things that are addiction or mental health issues, yes, absolutely, those have to continue because we don't have enough people to see them one-on-one in our offices.
I think it's going to have to be like the pain clinics because, we had the runaway fly-by-night, just taking money before we passed the rules, the law that lets you put into effect the rules for those. And it's cut down on it tremendously, the problem. So we do have good clinics like Emory and
absolutely.
So I know y'all will consider that when y'all are making the rules.
Thank you. I will make sure we do. Yes, sir.
Sorry, I had a couple quick questions. The PAIN Act, obviously we're talking about that, was, as a practitioner, was one of the best things I think that ever happened. Legislation-wise, a great example of how it really helped us in the community be able to, handle patients. But the question I had is, okay, so now we have this act and you have to register. How are we regulating, or how are we handling clinics that are prescribing more than 50% or whatever, basically should be registered as a pain clinic but are not? Is there something in place to find the ones that aren't self-reporting as a pain clinic but are hyper-prescribing medications?
Well, anybody can make a complaint to the Composite State Board, whether you're an employee or you're just a consumer or you're just a passerby. So we get a lot of complaints, and we also, people say, well, there's a lot of strange cars out there at all times of day and night. We get all those complaints. I guess they come in from a lot of different directions. Pharmacists might send a thing, we're getting 50 prescriptions a day from this practice. And then we have on the Composite State Medical Board officers that are investigators that go out. They do undercover work to see if that's really going on. They carry guns, they have bulletproof vests. That's what y'all helped pay for when you gave them some increases. These are trained professionals that are officers, investigating officers, and we have an investigative committee, and they come back and report to us, and they may say, we went to see clinic in somewhere Georgia, and this is what we found, and so we start a deeper investigation. Quite frequently, from my experience, as these people get on the radar, then the DEA gets involved. Most of these people are not reporting all the income. The IRS gets involved. So it becomes a multi-agency that suddenly everybody descends on them and shuts them down. It's not just this Composite State Medical Board that shows up. When there's something really nasty, unfortunate going down, and there'll be one in the next month or two, I'm sure. Or at least within the next 6 months in Georgia. I have no doubt, because those are ongoing investigations that are all undercover right now. But beware, if you know a good friend that's not doing the right thing, they will eventually find you.
That's fantastic. I didn't realize that we had that level of regulation. That's good.
Yeah. It's just serious when you are not doing the right thing.
Do we ever monitor, by prescribing practices of physicians based on maybe their specialty? For instance, if you're this is the sort of the prescribing pattern for this type specialty, or what these people typically do, pediatricians, for instance, and if you have one prescribed, there's a little bit of an outlier. Is there some sort of system to find those outliers? For instance, if I saw pediatricians prescribe very little opiates, because typically they don't, and then you had one person who's prescribing a lot, is there something in the system that finds those, or is that?
With the PDMP, that is monitored through the Department of Public Health. They can kind of present those outliers, but a lot of times it's the pharmacists that are seeing that many prescriptions, and like I said, the PDMP is a great tool to kind of look at that. And
we empower, I guess, the pharmacists to do that, to call and say, hey, I'm seeing a lot from this one person.
Absolutely.
That's awesome. I didn't know that.
Absolutely. And you empower every citizen of Georgia. if you as a citizen are feeling like I said, you're seeing something going on in your community that doesn't look right, the wrong kinds of cars are there, or, you know, there's just all kinds of people there, you know, they're usually there, you know, at the same time, or we've had people have, you know, carloads coming in from Tennessee or Kentucky. Well, you know, every Thursday there's a carload of folks that show up from Tennessee or, you know, another state. People, that's, you know, reported just the neighbors coming to this clinic, you know. So anybody in the state of Georgia in any capacity can file a complaint, and they're all looked at. That's kind of why we need a lot of, I think it's over 1,000 complaints. I should know a month how much we get, but we get a lot. You know, some of them are looked at superficially. You know, I didn't like the dress that the doctor wore today. It was inappropriate. You know, those are kind of taken not as seriously. But if you said, I think this doctor is overprescribing, those get to the top of the list pretty quickly. Yes, sir.
Presentation, Dr. Cheek. I had two questions. You know, one kind of going off of what Dr. Askewy said of prescribing habits. You know, PDMP is a fantastic tool, and I think you said 19 or 20 states now utilize some form of this. Is there a benchmark for what we want to do? I know this is, again, up to the physicians and their prescription habits, but if one state, you know, shows X amount being prescribed and the other shows Y and the other shows Z, is there been any way that they're looking at how to standardize that, to look for what would be a goal? And coming back to, again, what Dr. Askewy said, the prescribing habits, if you have 1 million, you know, orthopods in one state and one pediatrician, and the other state's 1 million pediatricians and one orthopod, you know, to kind of use a formula to see what can you expect in regards to opioid prescriptions?
Mm-hmm. Yeah. What I was saying, 19 states right now in the PDMP in Georgia, we're able to see 19 states in the District of Columbia's data. 49 states in the United States have a PDMP. Okay, so we're not connected to all 49 states. Just like medical records, which I'm sure you're aware of, the connectivity issues with different registries across any type of medical field is a challenging problem, but we have made those connections with 19 states. The Georgia PDMP wants to get to the 49 and, you know, the 50 if we could ever, you know, get that. So yes, those connections are there. To my knowledge, and I might not be well informed on this, there's nobody looking at the national data that's coming out of the ones that are connected, and I think that's a very good opportunity from the United States across the, and I don't know what commission would look at that, I guess, I don't know, somebody in Washington, but to my knowledge, nobody's looking at that, but it would be a really good idea. And I think as more get connected, where we probably get all 50 states looking at it, then we can look at national levels. Again, the major way that we spot outliers is someone holds up their hand and says, take a look at this person. That's the major way.
Thank you. Yeah, I think with a PHE, public health emergency with opioids, we'd want to have some end zones to target. That's what we did with a lot of infection control in this country, looking at different infections. So I think that'd be hopefully something all 50 states would want to work together with. And then the last question is just on what you talked about, the 8 hours for the DEA or federal requirements. Have they put parameters on what, and that's great that there's 8 hours, I didn't even realize that, but what detail needs to be in there? And if not, is Georgia able to mandate any more specifics? You know, I did my own training previously for the 2 or 3 hours it was required, and it was a pretty easy road, whatever I selected. But is there a way Georgia could come up with, I don't know, a slide set that talked about the addiction potential of prescribing, you know, opioids to somebody that's never had them, et cetera, to show what this could mean, so that Georgia, if the feds don't have, and you may tell me something different, but if they don't have that, is there a way we could do that as a state to put something together and say, for 3 of those 8 hours or 2 of those, you know, this is what we would like you to do?
Yeah, yes, you have to have an approved course. So the DEA has courses out there that are approved for their 8 hours of credit, and they are approved in different specialties. So like the American Academy of Pediatrics put out an 8-hour course that was approved by the DEA to meet all the requirements that they had for opioid prescribing within the pediatric community, and also for the other specialties. So there are, you have to have a course that is approved by the DEA, and they have standards that have to be met. So.
I think that one of the things that we want to make sure, and how these things work, that we don't run into the same problem as that we do with the maternal mortality issues, is because some states, only record things for 42 days after the birth. Some do a year, and they're all lumped together. So you're doing apples to oranges. And some states on their PDMs may require that only Schedule IIs are put in, or so this is a problem. The states are different. Nobody says that you have to do all of them or whatever. So it would be a comparison like that would be really hard to do, and could really be skewed because it's not consistent on how we do things. Best thing to do would be for the board, and I think they do this, to look at what we're doing in individual prescribing, which public health has the right to do. The only thing I was going to ask, okay, is the reason that we only share with 19 states, is there something in our law that restricts us from sharing with the other ones that have PDMPs?
Now, the legislators would have to ask that. Okay. I think probably the reason is that just the logistics of the connections are being worked out. Not everybody has the same platform that they started off with, and I'm sure there's different venues, different people that sell different products that, one state buys this product and the next state buys this product, and they don't talk to each other.
Well, I think Dr. Sheik is right. One of the problems might be, and we'd have to go back and look at the law. When we first started, we couldn't share with anybody, thanks to a House member that's now a senator. And we had to go back and change that. And but it seems like at one point we could only share with states that shared with us. So I don't know, it'd have to be something to go back and look at it. There's a reason why we can't share.
You can look, but I think probably the goal is to share with 49. It's just the logistics of the connections are probably the problem. But you can ask Department of Public Health, Dr. Toomey, or Dr. Rushkin next time they present to y'all, and I can try to get information to it. But I suspect it's just the logistics of the connection.
And we've changed it over the years. Like at first we couldn't share with anybody, and so I know we have changed it a couple of times. I'm sorry.
We have one more final question.
Brief question, and you didn't touch on this exactly, but I thought about it when you were talking about medical directors for pain management clinics. As it relates to like drug treatment facilities and medical directors for those facilities, are there certain criteria, and maybe this isn't under your umbrella or within your purview, but certain criteria that or I guess checks and balances that make sure the medical director is actually qualified to do that? Because what I'm seeing, and granted it's a bit anecdotally, is that you'll get like a cardiologist, for example, just gets offered, you don't have to hardly come in and we'll pay you X number of dollars to just stamp as our medical director of this facility, but it's someone without actual knowledge or experience in the area in which they're serving as medical director. Are there any checks and balances?
Now, there's checks and balances on the pain management clinics because there's a long list of laws that are set in place, and those people have to renew their license every 2 years and have to give regulatory papers documenting that they're doing what they're supposed to do. Now, in terms of medical directors of other things, like medical directors of spas or whatever, not nearly as much restriction that person has to be in that, I guess, specialty. But pain management clinics in and of themselves are pretty well regulated. Would you not agree on this? There's a lot of things a lot of hoops they have to jump through to maintain their pain management.
You have to have a pain specialist, right? You have to be board certified, which actually the board doesn't typically require board certification, but this is one situation where they do. So this is one where you do have to have a pain management board certification to be a medical director. So to your question, you can't be a cardiologist.
Not for a pain management, but then once the person gets addicted, a cardiologist can be a medical director of a behavioral health facility.
Well, but they can't prescribe narcotics at that level.
Right. No, I get that they can't prescribe it. I guess my concern is, are these facilities actually helping people, some of them, or like?
Oh, I see what you mean. You're exactly right. A lot of addiction and, places that are set up to help people with addiction, there are, I don't know that there's stringent regulations on those people. And you're right, a lot of them are just take advantage of the public and addicted individuals.
Like you have a vulnerable population.
They sort of take care of them until their ability to pay runs out.
Yeah,
we've seen that. To my knowledge, the Composite State Medical Board does not regulate those type of entities. But as a private physician and a physician and a person, I've seen those situations where I think that there are people that run those kind of, recovery clinics that, shall we say, I'm not sure that those people are getting what they need to actually recover. But we don't. The Composite State Medical Board has no jurisdiction over those.
Okay, thank you so much. Good questions. Thanks, everybody. I do want to tell you, it's kind of interesting. I just noticed something recently. In Rome, I've seen a lot of signs over the years, and they're not necessarily linked to a clinic. The yard signs that will pop up on corners, high traffic areas. I had just said how I hadn't seen any in a long time. They've just started showing up again, and I have a theory that it's when other signs are up too. They're not advertising clinics, they're advertising a phone number for pain. So I feel like they look for opportunities when there are other signs and they might be lost in the mix of things. So you might be getting more calls pretty soon on that kind of reporting. But thank you so much, Dr. Cheek, and please tell Dr. Ben Cheek how much we all do appreciate him.
Oh, thank you, and thank y'all for this opportunity to be called. If you have any questions, I'll be glad to help.
Thank you, thank you. Okay, we have one more presenter, Maria Thacker, the President and CEO of Georgia Bio. And Maria, when you come up, if you would just tell us a little bit more about yourself to introduce us to you.
Good afternoon, everybody. Thank you for having me here today. My name is Maria Thacker. I'm President and CEO of Georgia Bio. We're the trade association for the life sciences sector. I know we're short on time, so please interrupt me if you have a question if I move a little too quickly. But when I say we represent the life sciences sector, that is the biotechnology area, the medical device or med tech area, and literally everything in pharma and everything that comes under that. So we're the only association in the state that works in this space, and we do, of course, advocacy, a lot of education in that arena. So please know we're a resource for you all anytime you need it. We connect the community and have a big resource of companies that are based here in Georgia that would always be welcome to connect with you. And we also do a lot of STEM work and have an outstanding partnership with the State of Georgia Department of Education to build workforce for this industry, particularly in the manufacturing space. So that is me. I was asked today to talk about how a drug comes to market, and I hope you don't mind, I took a little privilege. We're going to talk about how a drug and a device comes to market simply because of what your industry, your committee is looking into and trying to understand, because it's not just drugs that can help with pain management. There's a lot of alternatives in the device space as well. And I will, on a personal note, share that opioid addiction has touched my family directly, and through over a decade of experience going in and out of treatment for that family member, and this is a very personal issue for me, and I also am personally a patient in the industry. I have a permanent device in my heart, and I have been through, almost lost my leg, and I've been on various therapeutics and drugs for this. So I am very much a patient and sit in this in a personal space, but also here to help you all educate and understand this rather complex world of bringing a drug or device to market. So the FDA was founded by President Roosevelt over 100 years ago in late June of 1906. It was really about helping find a way to bring safety to what were drugs and treatments then. And it has certainly evolved over the last 100 years. And a key piece is about protecting public health. And the first word out of that is assuring the safety, efficacy, and security of human and veterinary drugs. And again, you know, we really are working at the FDA to advance the public health by helping speed innovations and bring them to market to make them more effective and safer, to help accelerate those treatment and cures and innovations to bring them to patients. So the FDA is a very large agency, and we're not going to cover all of this. I am going to touch on a few of the centers, which are going to, I don't know if I can do this, yeah. So the Office of the Commissioner is the big box at the top, but I'm going to touch on the centers in the next level, particularly 3 of them that are right here. But before I dive into those 3, I do want to mention the other ones so you kind of understand how it's not as simple as one center within the FDA because of how complex the different science is depending on what's getting approved. So, of course, the Office of the Commissioner is led by Commissioner Dr. Califf, and he really oversees the whole entire federal the agency for the FDA and the entire portfolio. So all the centers report up into his office. And the centers I'm not going to do a deep dive into, I am going to touch on now, though, include the Center for Food Safety and Applied Nutrition, which safeguard, of course, our food and cosmetics and dietary supplements to a point. And the Center for Tobacco Products, there's a whole center specifically on tobacco use. The Center for Veterinary Medicine that ensures really all the animal drugs, they're safe and effective. And just one local point on this, in Georgia, we are the U.S. headquarters for Boehringer Ingelheim Animal Health. They have very large R&D and manufacturing sites up in Athens, Georgia, and some facilities and main offices in Duluth. And the reason this is important is their particular facility is regulated and it is allowed to manufacture human vaccines as well in case of an epidemic. So we're one of a handful of sites in the U.S. that can do that if needed. They can, you know, flip their site and manufacture for humans as needed, but it is developed for animal vaccines right now. Additionally, there's the Oncology Center of Excellence, and that's going to be anything medical products related to hematologic and cancer malignancies. And then, of course, the Office of Regulatory Affairs, which is always busy, and they're really to ensure the public health is protected, promoted, and advanced. So I want to focus on 3 particular centers. We're going to start with the Center for Drug Evaluation and Research. So the center for this particular center really focuses on traditional drugs. It's going to be a lot of the over-counter things that you buy when you go to a Walgreens or a CVS or a local pharmacy, the Advils, tablets, capsules you purchase. It can even be sunscreen, dandruff treatment on your hair, head, scalp, whatever. And it is the largest because of how many over-the-counter products that we have. The next center is the Center for Biologics and Evaluation and Research. So this is going to be a biologic. And when we're talking a biologic, and I'm so sorry, I'm realizing I don't have the same slides you do. This is anything that comes from a living organism. So a biologic is going to be based in blood, plasma, anything that comes from us or something that is a biologic, and has. These are going to be things like your cell-based therapies and vaccines. And I just want to bring this a little bit local. Georgia Tech houses CMAT, one of the largest NSF centers for cell manufacturing, and it's a really big thing for us here in Georgia. It's housed at Georgia Tech, and it's doing a lot of innovative therapies around genetic and cell-based therapies. Did you have a question? Okay, just making sure. Yes, sir.
You had amoxicillin OTC. Mm-hmm. When did that happen?
That is a question above. I do not have at the top of my head. It doesn't necessarily mean OTC. That list is just regulated by this particular center. Things like, sorry if I wasn't clear, just things that are like over-the-counter, like your Advils, but there are some that are not over-the-counter, like amoxicillin. Yes, that is definitely not OTC. Right. I bought it for my 7-year-old. I had to go to the pharmacy. So again, it's a very small center when we're looking at the Center for Biologics, but it is tremendous growth happening there, particularly with the amount of research happening in our research institutions like the one we're housed at today. And Again, I wanted to bring in devices into this because this has a lot to do with pain regulation for patients, and that is regulated by the Center for Devices and Radiological Health. This particular center, like I said, regulates medical devices, which in the industry we also call med tech these days, so you may hear med tech and devices used interchangeably, and anything radiation emitting products. So there are different classifications, just like in the previous presenter mentioned, there are different classes in her world. There are in the medical device classification world as well. And those 4 classes plus de novo, 3 classes plus the de novo area are presented here. I think it's very important to note that even something as simple as your Band-Aid is considered a device, all the way up into those the pacemakers, a device like I said I have in my heart. They're different classes, and then they have the de novo section that doesn't really fit into a class. So in somewhat of a summary for these particular centers, we've got, the CDR. So that particular, again, that is new drug applications and generics are going to be under this particular area. Under the CBER, you're going to have a lot of the biologics and biosimilars are going to fall under here. You probably heard that before. I know we've done a lot of activity in the biosimilar world here in Georgia. And then the CDRH is going to be the pre-market authorization as well as 510K. A 510K is a class 1 or 2. It's a more of a low-risk particular therapeutic. And then in the CDRH is going to be the pre-market authorization, and that is more of the high-risk drugs, class 3 drug or higher. So if you're looking at the product development process, you may have thousands and thousands of compounds that start in this process in a pre-discovery phase within a university environment. And then over the course of multiple years, as you can see under here, it is going to be one FDA-approved drug. So if you look at the timeline at the bottom of this, just the discovery phase can take up to 6 years, and then you get into the clinical trial phase, which again is 6 to 7 years. And then when you get to the final approved product, it's just a couple. So when the industry says it can take 10, 20 years to bring a drug to market, this is what we're talking about. The research piece is a big piece of it. So again, the regulated biopharmaceutical industry, we have a number of different phases. There's preclinical. You hear a lot of that from our research universities working in the preclinical and phase 1 arena. And then again, in moving into phase 2 and then into the market space, we have we move into more of the clinical trials phase and understanding how the market is going to receive the product a bit more and how we're going to bring that fully commercialized to market, and then how we're going to scale and grow that, and then move it again into the generic competition once the patents have run out at that point. So, and I'm sorry I'm going through this a little quickly because I want to make sure I can answer any questions you all have. The medical device approval process, again, it's going to go through the same safety rigor, but it is much shorter. Bringing a device to market can take about 8 years on average or less, honestly. It's much faster to bring a device to market. I will note that the federal government and FDA are continually changing those medical devices that are integrating digital technology into it. The regulation is often changing and often being reviewed. I would like to say we fully understand it, but we don't. And there's still a lot of understanding that the industry as a technology in the world of AI and data analytics continues to progress at a rapid pace. The industry and the regulations around it are going to evolve. But bringing a device to market is a faster product, but there are a lot of great products in the device space that can help with pain management for patients. So another way to look at this, and I know you all will be provided with these slides, which should, but I'm always here to answer any additional questions. You've got on the left side the various phases of bringing a drug to market here. I'll mention the phase 4, which wasn't on this. There's continued studies that are done when a drug or comes to market, a post-approval study, as well as this long-term data on what happens with patients. So sometimes over 20 years of use, you might find new indications that we need to be mindful of for the patients. At the top of mind for every single one of these phases, whether it's a device or a drug, is safety. There's a reason safety is the first bullet for every single thing, and that is at all points in the process, whether you're drug discovery or you're manufacturing of a drug to bring to market. You can go onto any manufacturing floor, the first thing you're going to talk about is safety. And that is critical for our workforce as well, of course, as the patients. Medical device, again, it's going to go through various phases as well, a little bit more fast-tracked, but when you look at this, there's usually a lot more people that they can do in clinical trials when it comes to device. And again, in the end, it's about to determine effectiveness and any adverse safety issues that we need to be mindful of. I wanted to bring up expedited processes. I know during COVID, there was a lot of information from our industry that was thrust upon the public, such as emergency use authorization and fast tracking something, and it could create a lot of concerns out in the media. So the 5 up here are what I wanted to just highlight right now. I'm not going to read through this, but they're all different. There's lots of many podcasts you can listen to, great information online. There could be a presentation on each one of these bullets alone. But I think, if there are any specific questions, I think there's some detail on this slide that will be helpful for you, but there's going to be more different types of meetings and administrative oversight with the FDA, depending on which one of these fast tracks you're going through. There's also going to be different guidelines under each, and different timelines depending, and oversight depending on what pathway you're going through to bring whatever your treatment or therapy is to market. There are also breakthrough device programs as well for the device market. There's new guidance that just came out last summer, and it replaced some old guidelines. These guidelines are constantly reviewed and updated on a regular basis, whether it's devices or pharma and just drugs. Just in order to make sure, as we learn more information, as the science evolves, we learn and we adapt based on what the regulations need to be, so we can continue to remain safe and for our patients. For the sake of time, I was going to talk about this because there's a lot of conversation for 2 slides on mRNA vaccines. There's a lot of research happening in our state here. There are 2 pieces of this regulatory pathway, of course, the FDA, but there is also an oversight committee out of CDC after the FDA has made a recommendation that gives the final recommendation. I think a lot of the public learned about this with the COVID vaccines, of course, but again, it is another round of an independent oversight for the regulatory and safety of whatever that treatment may be. And there are many systems in place to continue to ensure that vaccines are safe. This slide is online that summarizes it. I think this is more what you all are going to want to see. Despite the number of preclinical research and drugs that start out at the front end of that earlier timeline I mentioned, typically about 55 come out of the CDER at the end of that entire 15-20-year pipeline annually, and then 25, these are the 2033 numbers, but it's pretty average. I think it was a little bit higher last year that got approved. About 25 biologics get approved by the FDA and about 52 medical devices. So you can start with 10,000 plus different ideas, and at the end of the day, only a handful get approved in a year. And then finally, I just want to give you a slide on emergency use authorization versus the full FDA approval. So I think it is really important to note that in the end, it's a timeline that is condensed, but in the end, the rigorous standards of bringing something to market, whether it's under an EUA or a standard pathway through the FDA, are the same. It's just as rigorous. The program for the EUA was established in 2004. This was really, I believe it was in response to anthrax. It was an environmental concern, so that is why the EUA process came in, and it's honestly been shown to be really useful for a lot of other things. It is the same process, but only faster. There are vast differences in the resources. So one of the things that we'll hear from most people everyone in our industry that's running a company is COVID-19 was a unique point in time where we had a lot of money and everybody was coordinated to bring things to market quickly. That is not how things typically go. Most of my CEOs that run companies in this state frankly, any state in the Southeast and the South, because most of the venture capital is not here, are not here on the ground. They're constantly traveling, raising money for a phase 1. We were able to, as an industry, bring those therapies, those vaccines and therapies to market very quickly because we were in a global pandemic. That is not the day-to-day of our industry. So, at any point, an EUA can be revoked. I think that's very important to know by the FDA. And they're constantly evaluating data. And then they will continue to gather data during that process after the EUA is granted. The timeline is shorter, but in the end, the regulatory oversight is still there. They just might be, everything's being done in parallel while a manufacturing site's being built and while the drug is still being studied, while they're going through clinical trials. All that's just happening in a much more coordinated across the industry, along with government and health systems, to bring whatever needs to be done to market to help tackle whatever that public health crisis might be. So I tried to pull together a quick slide that just compares the two sides of an FDA versus EUA pathway. It tends to be on the FDA vertical. It is a step-by-step, and with each one of those steps, our executives are having to raise money to get to that point. I have many companies that are ready for a clinical trial, but they'll spend 2 to 3 years just raising money just to be able to do a clinical trial with 100 people. Under an EUA, usually the patients are already there and the money's there and you're just pushing through this. So again, I just want to stress that a lot of it is the resources and administration around it that allow for things to get expedited. It's not because the science and the safety are not being addressed in the same way as they would under a standard pathway with the FDA. So again, the timeline is condensed, but we still hold the strictest standards possible. So I was trying to be mindful of time. There are so many things I could talk about under each center, but I wanted to see if I could answer any questions that have come up in any of your previous meetings. It looks like you have one, Ms. Payton.
I do have a question. You spoke about some pain management devices. Are you able to speak to any of those and how they are performing in the market?
Yes, I can bring up, there are some, I think many of us are very familiar with TENS devices. If you've ever had that is one thing. There is a lot of data around electric use, but also vibration that can be used for pain management. We have a local company called Pain Care Labs run by Dr. Amy Baxter. She used it, she was actually on Shark Tank and turned down a deal. She has a device that is an over-the-counter device. You can buy it online however you would like to. It is used for needle fear. And things like that. It was very much scaled during COVID for that use, but she also has another device that is in the middle of going through the FDA pathway right now. I don't know the status of that on the market right now. I'd have to check with Amy. But that's just a local reference again, and I'm sure Amy would be happy to come speak. She's an excellent speaker about pain management without having to use opioids. It's a passion of hers. So.
Thank you so much.
And I'm sure I can find more if you would need me to do that. So, but I think it's important for the committee to know it's not about necessarily finding another drug. There's also therapies that can help patients. And I think, the doctor before me mentioned some things as well. There are other alternatives to helping with this issue. Yes, sir.
Do you think there's any scope for artificial intelligence applications to reduce the manufacturing lead time? Because it's particularly good at like folding molecules to make virtual compounds. Do you think that could either reduce the number of compounds tested or reduce the timeline to bring to market at all?
I'm going to broadly say yes, but I'm going to say the industry is still understanding that, and then the regulation around that is also still being assessed. I think right now there's a lot of focus on working to bring any type of drug, therapeutic, or device to market more quickly by helping to expedite the clinical trial process as well as the manufacturing process, but we have to be mindful of course, considering safety and making sure there's no error that happens through that. AI is not perfect, just like humans aren't, and this is an area that we don't want to leave any particular area for room for error for the manufacturing process or even the research. There's also, I do think there's a lot of capacity and a lot of research, a lot of papers and discussion around how AI can be used to improve data analytics and make more efficient decisions on the research end, that preclinical stage though. That's where we're gonna see, I think, some of our big companies in particular doing, using some of their funds to understand how we can get treatments to market more effectively and faster. Mm-hmm.
Thank you.
Yes, but it's early. Yeah.
I would like to thank you for all your years, your years in Georgia Bio,
Yes, sir.
for providing information to us at the Capitol and all your work that's promoting and providing new drugs and pathways and treatments. Y'all have done a phenomenal job, and I appreciate it.
No, thank you, sir. It's been great to work with you, and please don't ever hesitate to reach out. We're here to help connect you with industry, too, to talk about these issues. So it's important to us. There's another company as well, I'll note, that works with opioid pill cases, but they're secured and they use AI and, not AI, they use technology to talk to the physician directly on how because there is a role for opioids in our market for pain, but on how that can be controlled and how they're distributed. And there's a local company here that can also be brought in to talk if needed about what he's doing. So, All right, any other questions?
All right. I don't see any thank you, though. You got our wheels turning again.
Great.
And I know when everybody gets this information, like I said, electronically,
All my
we'll
references.
all dig into it again and look a little bit more, may have some questions. And,
Yes, ma'am.
Y'all reach out to us, reach out to me, Morgan, and we'll connect you if needed to help with that. Thank you again for the work that you are doing in Georgia.
Thank
Appreciate it.
you, and if you need anything, don't hesitate to reach out.
Thank you. Thank you. Okay, well, that brings this day to a conclusion here, and we will be in touch with you very shortly, probably next week, with some information about the next meeting. Right now it is scheduled, I believe, for October 8th and 9th in Rome. It will be an overnight for those of you that want to stay. We'll send you some information about a hotel, we'll have dinner, we'll dig into a lot, because that will be the last two meetings really before we come back together in Atlanta and try to assess much of this and see the appetite to move forward on some things. So as you all travel back home or wherever today, be careful, be safe. Looks like the tree's still blowing out there a little bit, but just it's great to see y'all. Thank you for the contribution you're making to this discussion too. And I want to say thank you again, especially Justin's done a great job of helping us do this off-site and doing it well. I just thank you so much for that. Also to Morgan, who put together another great meeting of speakers, and then those who hosted us here. So President Underwood and Dr. Sumner, but also Hugh Soseby, who made sure that none of us were hungry today and could find our way here. Y'all be careful. Look forward to seeing you again. If you have any questions, please reach out.